இல்லை ஸ்லைட் ஷோ கொடுத்தா அவங்க HDMI 1 மாற்றிட்டாங்கன்னா
ஆல்ரெடி
என்னோட மவுஸு
Good morning to everyone gathered here. It is our honor to welcome you all to the scientific session of TAPICON 2025. We warmly welcome you all. I now invite our chairpersons, Dr. Panmadi from Erode, Dr. Philomena from Vellore, and Dr. Narasimhan from Sholingar, to kindly take the stage and lead the session. We begin with the first talk. Dr. RBS Manian from Chennai will speak on an approach to secondary hypertension.
Very good morning to one and all. It's given me immense pleasure to be here to talk about the secondary hypertension. As we all know, that hypertension is the most common risk factor for cardiovascular diseases, and more than 30% of the world population is suffering from this hypertension. And among these, 85 to 90% are without any identifiable underlying cause. So they comes under essential hypertension. But about 10% of these hypertension patients are having secondary underlying cause, that is called secondary hypertension. Coming to the prevalence of the secondary hypertension, prevalence is more common in the extremes of the age, and 70 to 85% of the patients are children with less than 12 years of the age, and 17% are above 65 years of the age. 10 to 15% of the patients are among 12 to 18 years of the age, and it is least common among aged 19 to 39 years. Causes of secondary hypertension are renal parenchymal disease or renal vascular disease, endocrine causes, drug-induced causes, coarctation of the aorta, obstructive sleep apnea, pregnancy-related hypertension, and large vessel vasculitis. Coming to some endocrine causes, adrenal gland dependent causes like primary hyperaldosteronism, that is Conn syndrome, is the most common form of secondary hypertension. Then pheochromocytoma and paraganglionoma, Cushing's syndrome, ACTH dependent or independent, pituitary gland tumors, Cushing's disease and acromegaly, hyperparathyroidism, and thyroid disorders. Both hypo and hyperthyroidism will have impact on hypertension. Coming to the age-specific causes of hypertension, in between children from birth to 18 years, up to 18 years, which is on prevalence is most common between birth to 12 years. Renal parenchymal disease and coarctation of the aorta leads the cause. Then between 19 to 39 years, thyroid dysfunction, fibromuscular dysplasia, renal parenchymal disease are the most common causes. In middle-aged adults, 40 to 64 years, hyperaldosteronism and thyroid dysfunction, Cushing's syndrome and pheochromocytoma are the most common causes of secondary hypertension. And adults more than 65 years, atherosclerotic renal vascular disease, renal failure, hypothyroidism are the most common cause of secondary hypertension. The detailed drug history is most important in evaluating the cause for the secondary hypertension, because the most of the drugs like estrogen in oral contraceptive pills, herbal drugs like ephedra, ginseng, illicit drugs, psychiatric drugs, non-steroidal anti-inflammatory drugs, steroids and sympathomimetics all will cause increase in BP. So the detailed drug history is most important while evaluating for the secondary hypertension. To whom we have to screen for secondary hypertension? Those patients with hypertension which starts less than 30 years, abrupt onset, abrupt worsening of the hypertension despite previous good control, hypertensive urgency and emergency, the resistance hypertension, and target organ damage if not proportionate to the degree of hypertension, associated with hypokalemia, high elevation of serum creatinine while starting ACE inhibitors or ARBs, and paroxysmal or labile hypertension. If these findings are there, we have to think about the secondary cause and we have to evaluate for the secondary hypertension. Coming to the general approach, before going for the evaluation, first we have to confirm whether the blood pressure is monitored according to the norms, standard norms, whether the BP cuff size is correct or patient is in the correct position or correct protocol is maintained. Then if we suspect white coat hypertension, we can do ambulatory BP monitoring and we can rule out white coat hypertension before going for evaluation of secondary hypertension. Then another important issue is drug compliance of the patient. Patient may not have taken the drugs regularly, so we have to get a detailed history about the drug compliance before investigating for the secondary hypertension. Then we have to review about the patient's dietary pattern, because high sodium, licorice and high excessive alcohol all will lead on to secondary hypertension. Then we will go for the detailed history and physical examination. After that, we have to go for regular blood investigations in all the hypertensive patients. Then based upon the clues we get in this, we will do targeted lab investigations and then treatment based upon the underlying cause. The routine investigations are complete blood count, thyroid function, liver function, renal function, electrolytes, urine complete, urine spot PCR, ultrasonogram and ECG. Coming to the certain causes of secondary hypertension, primary hyperaldosteronism, which is the most common form of secondary hypertension. There is a family history of hypertension and cerebrovascular accident in young age. Hypertension with hypokalemia will give us a clue. There is autonomous aldosterone hypersecretion, which is the most common cause for the secondary hypertension because of this aldosterone producing adenomas, idiopathic adrenal hyperplasia or abnormal aldosterone producing cell clusters. To whom we have to screen for primary aldosteronism? Whoever having severe hypertension, hypertension with hypokalemia, resistant hypertension, family history of early onset hypertension, family history of first degree relative with primary aldosteronism, stroke under the age of 40 years, patient with atrial fibrillation, sleep apnea and adrenal incidentaloма on ultrasonogram abdomen. For all these patients, we have to screen with for primary aldosteronism with plasma aldosterone renin ratio. It is the preferred screening test. It should be interpreted in the context of suppressed renin and elevated aldosterone levels. Patient with aldosterone renin ratio of more than 20 with elevated plasma aldosterone more than 10 nanogram per deciliter and suppressed renin of less than 1 nanogram per ml per hour or direct renin concentration less than 10 picogram per ml considered to be positive. While this test is positive, we can do other tests like adrenal vein sampling, which is the most complex procedure for subtyping, but not routinely done, then adrenal imaging to find out the tumors. While doing aldosterone renin ratio, we have to keep in mind certain factors that it has to be done 2 hours after waking up in the morning and with the patient in the seated position Hypokalemia will suppress the aldosterone production, so potassium level have to be corrected before doing the aldosterone-renin ratio. Unrestricted salt intake to maintain the volume, blood volume, so that the false results has to be restricted. And mineralocorticoid receptor antagonist like spironolactone has to be withdrawn at least 4 weeks prior to the testing, and temporarily replacing the antihypertensive agents with verapamil, alpha blockers or hydrolysin will be of useful to avoid false positive results. These are some confounding effect on aldosterone-renin ratio like mineralocorticoid receptor antagonist, ACE inhibitors, diuretics, beta blockers, hyperkalemia, pregnancy, aging. Every factor will have an impact on this ratio, so all should be kept in mind before interpreting aldosterone-renin ratio. The next one is the obstructive sleep apnea, which is the most another most common cause of this difficult to treat and secondary hypertension. History of snoring, daytime sleepiness, irritability, and poor concentration ability, and obese on examination gives clues about the obstructive sleep apnea as a cause of secondary hypertension. And it can be investigated with sleep apnea clinical score and detailed polysomnography either in the lab or in the house. Then renal parenchymal disease, which is the most common in the children. Glomerulonephritis and congenital abnormalities and reflex nephropathy can cause secondary hypertension. Patient may give history of high colored urine, or hypertension may be the sole finding. It can be investigated with blood urea nitrogen, serum electrolytes, urine analysis, urine culture, then renal ultrasonography, and if needed renal biopsy and nephrologist opinion. ADPKD is another most common type. Patient will give history of recurrent infections and kidney stones and flank pain. There can be hematuria or progressive renal failure. Ultrasonogram or CT abdomen will give us cystic lesions in the kidney. The renovascular disease, which is another most important entity in the secondary hypertension. In the middle-aged women, less than 50 years of age group with hypertension, we have to think about the renovascular hypertension due to fibromuscular dysplasia. And in the elderly, more than 65 years of the age, atherosclerotic renal vascular disease is the most common cause for this hypertension. The clinical clues are the worsening renal function with the ARB or ACE onset, early onset, abrupt onset, and resistant hypertension. And unilateral solid small kidney on ultrasonogram abdomen or any abdominal bruit on clinical examination will give us clue about the renal vascular disease. It can be investigated with CT angiography or MRI with gadolinium contrast. If contrast is contraindicated, we can go for renal Doppler study. Pheochromocytoma and paragangliomas, another less common cause, but one of the causes of secondary hypertension. Patient will have a labile or episodic hypertension, headache, palpitation, excessive sweating, and it is precipitated by the acute stressful conditions. The pheochromocytoma, the investigation of choice is 24-hour urinary fractionated metanephrines, plasma-free metanephrines, and imaging studies to localize the tumor. When the boys are of age group of around 5 years with hypertension, we have to suspect coarctation of the aorta. The clinical findings will be radiofemoral delay and difference in BP between the brachial BPs and brachial and femoral BP, and cardiac murmurs on auscultation. We have to think about the coarctation of the aorta, and thoracic or trans echocardiography will be of useful. If the patient is of adult age group, then we can go for MRI. Other chest X-ray signs like 3-sign and notching of the ribs will give us a clue about the coarctation of the aorta. The Cushing syndrome, as we all know that the external findings, we have a lot of findings in the Cushing syndrome like weight gain, fatigue, weakness, hirsutism, amenorrhea, moon facies, dorsal hump, purple striae, and truncal obesity. All these findings will give us clue about the Cushing syndrome as the secondary cause of hypertension. And late night salivary cortisol test twice, 24 hours urinary cortisol twice, or low dose dexamethasone suppression test, or CT abdomen to localize the lesion, all will be helpful to investigate Cushing syndrome. Hypothyroidism, as you all know, fatigue, weight gain, diastolic. Hyperthyroidism patient will have diastolic hypertension rather than systolic. Constipation, menstrual irregularity, and thyroid profile will be of helpful. For hyperthyroidism, weight loss, heat intolerance, loose stools, palpitation, systolic hypertension, exophthalmos, tremors, all will give clue about hyperthyroidism as a cause of secondary hypertension. Hyperparathyroidism also is one of the least common cause of the secondary hypertension. Patient will give history of kidney stones, recurrent osteoporosis, depression, muscle weakness, and serum calcium and serum parathyroid hormone levels will give us a clue about the hyperparathyroidism. And if you suspect scleroderma, patient will have a recurrent GERD-like symptoms, heartburn, Renal phenomenon, and nail pitting on examination. Autoantibodies against RNA polymerase 3 and ANA positive status and thrombotic microangiopathy in lab studies will give us clue about this scleroderma. All these tests, these lab investigations for the secondary hypertension will have the positive likelihood ratio and negative likelihood ratio, and most of the tests will have a positive likelihood ratio in diagnosing of the secondary hypertension. In pheochromocytoma, the plasma-free metanopyrin has a negative likelihood ratio. That means if it is normal, it rules out the pheochromocytoma. Then coming to the management aspect, it is a multidisciplinary approach whenever needed, and we have to treat the underlying cause, antihypertensive management with ACE, ARB and calcium channel blockers. Based upon the cause, we can go for either medical management or surgical management. If there is a offending drug, we have to withdraw the offending drug, proper dietary advice and lifestyle modifications. Approach to the primary aldosteronism treatment, as we have already discussed, aldosterone-renin ratio, we have to see if it is normal less than 20, it is not of unlikely of primary aldosteronism. 20 to 45, then we can repeat under specific circumstances, or we can go for adrenal vein sampling or any CT or MRI abdomen, and we can do subtyping. If it is a bilateral disease, medical management is indicated. If it is unilateral primary aldosteronism, then if patient is willing, we can go for surgical. If it is markedly elevated more than 45, it is primary aldosteronism diagnosis is confirmed. For renovascular hypertension, you have go for duplex sonography or CT or MR angiography, then catheter angiography. For fibromuscular dysplasia, if it is confirmed, then we can go for percutaneous transluminal renal angioplasty as the treatment. For atherosclerotic renal vascular disease, percutaneous transluminal renal angioplasty along with stenting we have to go for. Then we can do treat with antihypertensives also. For OSA, we have to do polysomnography, and based upon the apneic, hypopneic spells, we can categorize the patient to mild, moderate and severe. There are multimodal approach in the management of OSA and lifestyle modification, weight reduction and sleep habit changes, positional sleep therapy, then upper airway surgical procedures. We have bariatric surgery to treat the weight reduction, then continuous positive airway pressure so that it can have an impact on BP. Recurrently we have to, daily we have to advise the patient for positive airway pressure so that the BP will reduce from 6 to 10 millimeter of mercury. Coming to the medical management, primary aldosteronism with bilateral disease, as already discussed, only medical management, mineralocorticoid receptor antagonist and antihypertensive drugs. For renovascular disease, optimal lipid management with anti-lipid drugs and antiplatelets. For pheochromocytoma and paraganglioma, we have to first start with alpha blockers, then we have to add beta blockers. After that, if it is indicated, we can go for surgery. For malignant pheochromocytoma, we can treat with MABG and chemoradiotherapy. Then hypothyroidism, replace thyroxine and antihypertensive drugs. For hyperthyroidism, thyroid drugs along with antihypertensives. And Cushing's, we have to treat with glucocorticoid receptor antagonist and antihypertensive medications. Surgical management is indicated in secondary hypertension in the case of unilateral adrenal tumor in primary adrenal pheochromocytoma, and in Cushing's for ACTH or cortisol producing tumor, definitive therapy is surgical. For obstructive sleep apnea, indication for surgery is for upper airway corrections, and also for weight loss we can advise bariatric surgeries. For renovascular disease, for fibromuscular disease, angioplasty, and atherosclerotic renovascular disease, angioplasty with stenting. For coarctation as early as possible, surgery. Then coming to the overall approach, we have to first check whether the BP is monitored correctly as per the protocol with correct cuff size and correct positioning and correct without any observed variations. Then drug related causes has to be ruled out. Then proper history and detailed examination with basic laboratory findings will give us a clue whether there is any secondary causes. If we have a clue, then we can proceed with that. If we won't get a clue, then based upon the age specific causes, we can work up the patient with urine analysis, urine culture, renal biopsy, renal ultrasonography, then MRI with contrast or renal Doppler, plasma renin and aldosterone ratio, then MRI with gadolinium contrast, thyroid profile, then echocardiography to rule out coarctation of the aorta, then 24-hour urinary cortisol and metanephrines for pheochroma and Cushing syndrome. Then treatment is only about based upon the underlying cause, either medical or surgical. Thank you so much, and thank you for your passion learning. Herewith, I profusely thank Professor Chandrasekhar sir and organizing committee for giving me this opportunity to present about secondary hypertension in the TAPICON 2025. Thank you.
Thank you, Dr. Manian, for your valuable insights. Next, we have Dr. Radhakrishnan from Chennai will speak on osteoarthritis and rheumatoid arthritis and approach to investigations.
Yeah, that's the one. 25 minutes கொடுத்துருந்தாங்க. Okay. 9:50 to 10:15 போட்டு. Start பண்ணிடுங்க. No problem. Okay. Good morning, chairpersons. Good morning, learned audience. At the outset, I wish to thank API Vellore for giving me this chance. Okay. I'm going to talk on investigations in rheumatoid arthritis and osteoarthritis. What is rheumatoid arthritis? It's a chronic autoimmune disease. Primarily, it affects the synovial joints. There is inflammation in the synovium that leads on to pannus formation, erosion of the articular cartilage bone, and finally to joint deformities. This is the natural history or natural progression. But we as physicians can, if not stop, retard this natural progression. So that's the reason why this early diagnosis becomes very important. It gives us a window of opportunity, and that window is first 3 to 6 months of time. So, yeah, if proper disease modifying drugs are used and they are used correctly and for correct periods of time, then it's possible to prevent these irreversible joint erosions, deformities, and disabilities. So, if treated properly, swan neck deformity, bottlenose deformity, etc., should be confined to the history books. Yeah, that's the utopian thought, but we do come very close to it. And it also reduces the systemic complications which occur in rheumatoid arthritis, which can include myocardial infarction, other atherosclerosis associated diseases are found to be more common in rheumatoid arthritis, so are interstitial lung diseases. What are the challenges in early diagnosis? Most of the symptoms are not very specific because fatigue we see in a lot of other conditions. Morning stiffness, it only says that inflammatory cause is what is causing the arthritis, but it doesn't give the etiological clue for us. Symmetrical joint involvement can occur in a variety of conditions, and so the physical examination and proper history becomes very important. Morning stiffness for more than 1 hour, and if the patient is on NSAID therapy more than 30 minutes, symmetrical joint pain, small joint involvement, physical examination, the tender and swollen joint counts, and the pattern of joint involvement, all this helps in arriving at a diagnosis of rheumatoid arthritis. What is the role of investigations? We have seen history, we have seen physical examination. Well, to confirm the diagnosis, we need serological, it's not that we need, but if we have rheumatoid factor or anti-cyclic citrullinated protein antibody, it will help. Imaging in the early stages of the disease is not going to help much, but once erosion set in, investigations like MRI or ultrasound pick up early, then X-rays also pick up. But our aim is to not allow the patient to go or to develop erosive changes. Right? How are we going to assess the disease activity? C-reactive protein, ESR. Then clinical scores which are based on C-reactive protein or ESR and tender joint count swollen joint count, then physician's estimation or physician's analysis of patient global health, etc. And based on this, we have this DAS, that is disease activity score 28. 28 stands for 28 joints which are counted. Swelling and tenderness is taken into account. A score of more than 5.1 means it's very severe rheumatoid arthritis, and if it's less than 2.6, it means there's low activity going on. And if a score was severe or moderate and then it becomes either low or goes below 2.6, it means that we are treating with the right disease modifying drug and right dose. Then investigations are also required to monitor for complications like secondary Sjogren's, interstitial lung disease, etc. And what else do we need these investigations for? Before starting a DMRD, and to monitor the adverse effects and also how the DMRD works. So initially we do a complete hemogram, then for the first time when we see the patient, we do a full RFT including urea, creatinine, uric acid, full LFT, and screening for hepatitis B, C, because if we are going to use biologicals, it can flare up. Screening for latent tuberculosis for same purposes, and a chest X-ray. Out of this, once the patient is started on DMRDs, we need to do a complete hemogram regularly. Depending on the DMRD, it might have to be done in a month, 2 months, or sometimes even 3 months. Full creatinine, SGPT, and an X-ray if the patient is on methotrexate at least once in 6 months or once in a year. Okay, now come to the proper investigation. Rheumatoid factor, which is named after rheumatoid arthritis, though it is not specific to it. What is it? It's an antibody which is directed against the Fc fragment of immunoglobulin G. You see those pink ones, Y-shaped ones. The blue ones are the antigen binding site, FAB. The other one, the crystallizable one, FC, is to which the pentamer is attached, the green one. The green one is an IgM pentamer. So it attacks or it attaches to the Fc fragment of immunoglobulin G. Per se, this what I have shown here belongs to IgM, but it can belong to IgG, A, D, or even E. Initially, when Roswell was being used, it used to detect only IgM. Now we have investigations which are capable of detecting even IgG and sometimes even IgA and D. What are normal values for rheumatoid factor? Tighter levels are no longer used to that extent, so we'll switch to international units. Anything less than 15 is considered negative rheumatoid factor. Anything more than 60 is strongly positive, and intermediate values are mildly positive. Is rheumatoid factor found only in RA? No, because it occurs more commonly in primary Sjogren's syndrome, MCTD, though slightly less commonly, and even in rheumatoid it's seen only about 70 to 75% of the patients. It also occurs in a number of non-rheumatic conditions: hepatitis B, hepatitis C associated arthritis, primary biliary cirrhosis, which is now called cholangitis, primary biliary cholangitis, silicosis, asbestosis, tuberculosis, and healthy elderly individuals above 70, they also can have 5% of them can have a positive rheumatoid factor. Are there any other autoantibodies which help in the diagnosis? Yes. I was talking about ACPA or anti-citrullinated protein antibodies, of which one of them, the most commonly used, is the anti-cyclic citrullinated protein antibody or anti-CCP antibody. What is this antibody? The rheumatoid factor, I said, is directed against the Fc fragment of IgG. This is directed against the citrullinated arginine residues in proteins. Can be any protein, but most commonly vimentin or histone, etc. If you see the image on the right side, the arginine gets converted to citrulline. As we age, it happens, it's a normal aging process. Sometimes can get accelerated in autoimmune diseases. It loses an ammonia molecule and arginine becomes citrulline. These antibodies are directed against this particular radical. What is the relationship between anti-CCP and titers and tissue damage? Higher titers mean greater damage. And similarly, when we start DMA therapy, though we don't use it very commonly, a reduction in anti-CCP titers parallel the reduction in the disease-modifying drug-induced remission. Where else you can see, even this is not very specific to, it's not 100% specific to rheumatoid arthritis. It can occur in SLE, primary Sjogren's, psoriatic arthritis, tuberculosis, and other chronic obstructive airway diseases. Thus, anti-CCP is not to be done unless we have a moderately high pretest probability of rheumatoid arthritis. Okay, what are the normal levels for this? Less than 20 European units is normal or negative. More than 59 is strongly positive. In between values are weakly positive. Now, sensitivity wise, rheumatoid factor and anti-CCP are same, but specificity wise, there is a slightly better. Its anti-CCP antibody is slightly better. How do we assess disease activity in RA? So we finished two antibodies. Now we'll come to the commonly used ESR or erythrocyte sedimentation rate, and the other one we use is CRP. When both are increased, that is CRP and ESR, and continue to be high, that means there is going to be a lot of damage. Right, now let's combine rheumatoid factor, anti-CCP antibody, ESR and CRP on one hand, those are the investigations, with the pattern of joint involvement and duration of arthritis. Why do you want to combine this? Because these lab parameters help us to classify a patient with arthritis as having rheumatoid arthritis. Yeah, certain number of points are given for each one. The joint distribution, if only one large joint is involved, we cannot diagnose rheumatoid arthritis because the score is 0 and we need a score of 6. So what is on the right side, even fully add up, it is not going to work up to 6. 2 to 10 large joints is 1. 1 to 3 small joints is 2, 4 to 10 small joints is 3, and greater than 10 joints with at least one small joint is 5. Okay, RF and ACPA, if both are negative, it's 0. If either one of them is positive in low titers, it's 1, it's 2, in high titers, it's 3. Duration more than 6 weeks, 1 point, less than 6 weeks, 0 points. ESR and CRP, if they are normal, 0 points. If either one of them are raised, 1 point. So you need 6 points for diagnosing rheumatoid arthritis. So we'll start. Now let's say we have a scenario where common scenario where more than 10 joints are involved, small or big, but at least one small joint is involved. That gives 5 points. Is the rheumatoid factor and or ACPA, one of them is positive in high concentration or normal concentration, it's going to give us 3 or 2 points. So we diagnose rheumatoid arthritis. What if it's not even positive in lower concentrations? Then is the duration more than 6 weeks? If yes, that gives that 1 point. So you can diagnose rheumatoid arthritis. What if it's less than 6 weeks? Patient comes to you within a month. Then is this ESR and CRP raised? If yes, we can diagnose rheumatoid arthritis. If no, we have to throw rheumatoid arthritis into the dustbin. But this is an ideal condition. Sometimes there can be exceptions. This is developed by American College of Rheumatology, and also it's been certified by the European League Against Rheumatism. So, okay, then we'll go to the next scenario. What if 10 joints are not involved and only 4 to 10 joints, that is not, more than 10 is not there, but in between, any value in between 4 and 10 are involved, at least one small joint among them. Then you get 3 points. So we ask the question, is the rheumatoid factor or ACPA positive in high titer? If so, that gives the remaining 3 points and we diagnose rheumatoid arthritis. If not, the next question, is it positive at least in low concentration? So we are searching for that 2 points. If that 2 points are not there, then you cannot diagnose rheumatoid arthritis with certainty. But if those 2 points are there, it collects those 2 points and then we ask for duration more than 6 weeks. So 3 plus 2 is 5. If the duration is more, it gives 1 point, so we diagnose rheumatoid arthritis. Otherwise, we still ask another question, is the patient's ESR or CRP raised? If yes, we can still get a score of 6 and we can classify this patient's arthritis under the heading of rheumatoid arthritis. else we cannot diagnose. Now, what if not even 4 joints are involved? There are only 1 to 3 joints, but one among them is a small joint. That gives a score of 2. So the next question we ask is whether the RF is positive in high titer. If no, then at least is it positive in low titer? If no for that also, then we cannot diagnose. If yes, then we come back and ask whether the patient has arthritis for greater than 6 weeks. If no, again we cannot diagnose with certainty. If yes, we ask the next question, is his ESR, CRP raised? If yes, we can label the patient as having rheumatoid arthritis. Okay. Then there's one more scenario. The patient has got 1 to 3 joints and also has a rheumatoid factor in high titer or ACPA in high titer. So that is 2 points plus he is gathering 3 points there. So he needs only 1 point, either 6 weeks or if that's not there, raised CRP. Even if that is not there, then we cannot diagnose. This is third scenario. Now we will go to the last scenario. We don't even have 1 to 3 small joints. Okay, we have only 2 to 10 large joints. Okay, one large joint, of course, we cannot diagnose because score is 0. So this gives a score of just 1. Next question, is the rheumatoid factor or ACPA in high titer positivity? If yes, it gives 3 more points, so totally 4. Next is it present for more than 6 weeks? If yes, ask the next question whether the ESR or CRP is raised, and if yes to all of this, you can diagnose rheumatoid arthritis, else no. Okay, because of time thing, I'll just skip the remaining things. There are other antibodies also which have been developed of late, and imaging helps in diagnosing erosions. What we see in rheumatoid arthritis is juxta-articular osteoporosis, erosions of joints, and also erosion. What we see in this is erosion of the radial and ulnar joints. Ultrasonography is helpful, but it's got very high sensitivity, so sometimes it can pick up erosions which really don't exist. So is MRI, but ultrasonogram is being now used. Synovial fluid analysis mainly to rule out septic arthritis, crystal-induced arthritis. Then these relevant tests when we are seeing for complications in rheumatoid arthritis. Osteoarthritis, X-rays are by far the most useful modality. They are used to measure joint space narrowing, which is a surrogate marker for cartilage loss. So these are the things which we see in osteoporosis. Joint space narrowing, osteophytes, subchondral sclerosis, subchondral cysts, also called geodes, and deformities. So based on this, we have a classification. So I'm not going to go into this classification. This is mainly used by the orthopedicians to suggest to the patient whether he requires a knee joint replacement. MRI and ultrasound also help in the diagnosis, especially when there is suspected osteonecrosis, stress fractures, cartilage loss, etc. So that's about ultrasonography. Synovial fluid analysis, even here it's to rule out crystal-induced arthritis, septic arthritis, or sometimes inflammatory arthritis. This is how, if the WBC count is very high, more than 20,000, it's septic arthritis. If it's less than 4,000, 2,000, it's non-inflammatory. In between values, similarly, it just says they are inflammatory but not infective. Okay, thank you all for your patient listening.
Sir, you have really given an excellent view about the rheumatoid arthritis. When to suspect, how to go about, how to distinguish it from other arthritis, how to confirm, how to treat. I think without room for any doubts, you have cleared. He was telling that he has prepared the talk for 25 minutes.
So this algorithm, any other questions, sir?
Any of you? Yes,
no,
sir.
I'll start answering. Okay.
Sometimes anti-CCP antibody is negative, sir.
No,
So
no.
when should
RF
we-
is not required 100% of the time. So is ACP antibody. We don't require it because that gives only 3 points. We can if there is symmetrical involvement and more than 10 joints are involved, small joints are there, that gives 5 points. We need only 1 point. If this patient who is coming to you with symmetrical polyarthritis, inflammatory arthritis, has got a raised ESR, that's enough to diagnose for treatment. If it's more than 6 weeks, it becomes even more stronger. So, but after this COVID incident, we are seeing a lot of post-COVID manifestation, which presents almost exactly like rheumatoid arthritis. So what I do is I wait for at least 6 weeks before starting them on DMRDs. So when they come, even if it satisfies this criteria, I just put them on NSAIDs and for a week or so. Then I ask them to take it as and when needed, provided the renal function is normal. Otherwise, I just put them on paracetamol or tramadol, and ask if they cross 6 weeks and if they continue to have, then go in for DMRDs. And out of 10 patients, such patients coming post-COVID, at least 5 to 6 of them, when you see at 6 weeks, they're normal. So it disappears. It's transient viral arthritis. In fact, the most common cause for symmetrical polyarthritis is not rheumatoid arthritis. Symmetrical small joint arthritis is viral arthritis. Can be due to any number of viruses. Even before COVID, this used to be the common cause, but we didn't really wait that time. If you don't want to wait, if you want to play it safe, you can start them on HCQS. Instead of methotrexate, you can start them on HCQS and wait. If it's due to COVID, it will totally disappear. If it doesn't disappear, then probably you'll need methotrexate initiation. Even if with that it doesn't disappear, then you have to give him sulfasalazine. After that, target specific DMRDs like tofacitinib, which acts on JAK kinase. After that comes the other IL-1 blockers, TNF alpha blockers, IL-6 blockers, etc. They are more costly, okay, and they also have greater side effects. But my talk was basically on investigations, so that's why I didn't concentrate too much on the treatment part of it.
Yes, anti-MCV antibody, when should we do, sir?
Sorry, sir?
Anti-MCV antibody, you have talked about the anti-MCV antibody, sir. So usually we do anti-CCP antibodies.
MCV antibodies.
Anti-MCV.
MCV antibodies are just becoming available, sir. As of now, it's not included in the criteria.
Okay.
So it's mainly if you're doing it for research purposes, we can do it. And the only advantage is it's supposed to denote a stronger, it got a stronger correlation than anti-CCP antibodies. Both belong to the same ACPA class, citrullinated. They act on the citrullinated proteins. So, yeah, but we have to wait for that.
Okay.
As of now, either rheumatoid factor or if it is negative, we'll go for ACPA. There's no need to do ACPA also regularly. We are not going to monitor doing ACPA. Rheumatoid factor is negative because this is positive in 90% of the cases we do it. If that is also negative, it gives us more chance to ask the patient to wait. But that window period is important, 3 to 6 months. If you're going to wait for more than 3 months or 6 months, then it's a problem. That's why I said 6 weeks, which is 1.5 months. You can wait for that period, nothing is going to happen really fast, that fast.
Thank you.
Thank you.
Thank you, Dr. Radhakrishnan. Next, we have Dr. A.R. Balamurugan from Chennai, presenting on TB through the clinician's lens.
Respected chairpersons and dear faculties, and it's my immense pleasure to be here, and at the outset I would like to thank the organizers for the opportunity. The next 15 minutes I will be touching something about tuberculosis, what is meant by drug resistance, and what is the current scenario, what is the role of NTEB and latest guidelines. So TB through the clinician lens actually. So what are the TB statistics? We are all worrying about the diabetes, hypertension, CAD and CKD. But tuberculosis is still very common in India. NTB is aiming National Tuberculosis Eradication Program by 2025. It's saying that at the end of 25 there is no more tuberculosis. But even though you are 5 years ahead of global target of SDG 2030, we can see a lot of tuberculosis cases, especially extrapulmonary and disseminated tuberculosis. India has the highest burden of TB infection globally. Nearly 35 to 45 crores of population of India having tuberculosis infection actually. There's almost 2 deaths in every 3 minutes, 1,200 deaths per day and 4.3 lakhs of deaths per in a year. That means it's more than like diabetes, hypertension, RT and everything. So 5 to 10% of population of TB infection will develop active disease within first 2 years of infection. Especially it's more common in the diabetes and the other immunosuppression conditions like immunosuppressions, dialysis and other anti-cancer drugs actually. So recently we concluded that valid TB day, the theme of valid TB day is yes, we can end TB, but you can see a lot of TB and extrapulmonary tuberculosis actually. The theme is the commit, investment and deliver. So what is the current policy of NTB? So there is no more weekly thrice regimen. We are following right now fixed dose combination, daily regimen. There are basically 5 weight bands from the 25 kg to the 75 kg. So each weight bands contains 75 mg of isoniazid acid, 150 mg of rifampicin, 400 mg of pyrazinamide and 270 mg of ethambutol. There is no extension of the IP is required. So previously used to extend the IP for 1 to 2 months, but right now there is no extension of IP. They are saying that only 2 months of intensive phase and 4 months of the continuation phase. There is no category 2 right now, only category 1. Okay, there is at least DST should be tested for the isoniazid acid and rifampicin. That means we should not miss the isoniazid resistance. The previously we used to test only for the rifampicin, but right now we are testing for the isoniazid rifampicin. So all the CBNAT, that is category-based nucleic acid amplification test and otherwise called gene expert, sample should go for LPA, that is line probe assay. We can assess the capacity, we can get the results within 3 days actually. So blood is not an ideal sample actually. Blood, stool and urine is not ideal sample for the gene expert. We can have a tissue samples and other blood actually. Okay, but blood is not actually not ideal sample for the gene expert. This is the diagnostic journey so far. We had a conventional Zealand technique, microscopy, fluorescent microscopy, but right now we are having the gene expert ultra and then TrueNat and other mechanisms, LPA. So what is the turnaround time of each test actually? CBNAT, within 90 minutes we can get the reports with the help of CBNAT with the positivity and then sensitivity to the rifampicin and isoniazid acid. What about LPA? It's almost 3 days. So previously I worked in Tambaram Sanatorium. We used to wait for almost 90 days to 3 months to get the reports of the culture reports, but right now we are getting the reports within 90 minutes to 3 days and CBNAT 90 minutes and LPA by 3 days. Liquid culture MGIT, that is Mycobacterium growth indicator tubes, up to 6 weeks it will take. Solid LJ medium, it will take 12 weeks, that is 3 months. Right now we are having the whole genomic and targeted sequencing for the diagnosis of the tuberculosis. It takes almost 2 weeks actually. So how to proceed? You do have a molecular testing and then right now I said actually the gene expert ultra, and LPA, IS66110, targeted sequencing, whole genome sequencing, microscopy by conventional microscopy, fluorescent microscopy. Cultures always will be the LJ medium and MKit. Tissue biopsy always will be the gold standard and the ideal method to have the biopsy specimen. Biochemical examination in the form of ADA, adenosine deaminase, interferon gamma, and then protein, sugars, and LDH. X-ray chest and CT test will be taken whenever needed. We should avoid the unnecessary, costly, and invasive tests actually. So when to test the CBNAT? All notified TB patients, presumptive TB patients, high-risk population of the in the community, contacts of drug-resistant tuberculosis, smear negative X-ray suggestive of TB, including pediatric population, HIV population, and extrapulmonary tuberculosis. These are all the indications for the indication of gene expert actually. Then one word about the, sorry. So what's the difference between CBNAT and TrueNat? It's almost same. TrueNat is somewhat portable. It's both are having that RT-PCR method. But negative CBNAT, we cannot exclude the TB meningitis. In the case of lymph node tuberculosis, definitely there is role of CBNAT. Even though less sensitivity, around 35 to 40%, definitely they have a major role. As we are rightly discussed right now, stool, urine, blood is lack of specificity. Because of that, there is not ideal sample for the CBNAT. So right now we are having the site TB skin test. This highly specific skin test for the diagnosis of TB infection. It's designated to address some of the drawbacks of Manto and the IGRA. That means previously used to have a 10 millimeter positivity, but right now there is uniformly 5 millimeter positivity. The main advantage of site TB test is This is high specificity. If it is negative means we can, right royally we can exclude the tuberculosis infection. This is mostly exclusive of the, irrespective of the BCG vaccination achieved status, it will be positive means positive. The only thing is contraindication is allergic to the lactobacillus and lactis. It's almost less cost than the Manto test. So the contraindications are less than 18 years right now, but ICMR and Chetpat, other TB sanatoriums, they do only for right now, only for the more than 18 years. Household contacts of pulmonary TB, immunocompromised patients like transplant recipients, dialysis technicians. So definitely compared to Manto and IGRA, site TB test will be the ideal test for the, to confirm the tuberculosis infection. So Government of India recently, last year, sent the message to all the TB cell to have a utilization of the site TB. This one slide about the prophylaxis of tuberculosis. We used to have 6 months of daily isoniazid acid and 3 months of daily of isoniazid rifampicin. So 5 mg isoniazid acid, 10 mg of rifampicin. Right now we are having the, for the HIV population, isoniazid acid, rifampicin 1 month daily, that is more than 13 years. If you combine isoniazid acid, rifampicin, a weekly regimen of 3 months also available. Just remember, daily 6 months of isoniazid acid, daily 3 months of the isoniazid rifampicin in the case of lactation, pregnancy and other population. If you want to have a PLH population for the screening in community, so isoniazid rifampicin 3 months weekly and daily 1 month. So one more slide about the extrapulmonary tuberculosis. So almost 20% of all population of TB patients having the extrapulmonary. Disseminated TB means more than one non-contiguous organs. That means disseminated tuberculosis. But in the case of HIV population, it's almost 50 to 60% of extrapulmonary tuberculosis is a possibility. There's a lot of positive data from the clinical trials. What are the options available or everything because of pulmonary TB. EPTB, that means extrapulmonary, we do only positive trials. The guidelines developed by Dr. Sharma, 2014, next guidelines we are following right now. It's mostly hidden, mysterious, misleading, and mostly diagnosed which is delayed. We should be careful whenever we are dealing with extrapulmonary tuberculosis. It's not moving. So what is the treatment duration of extrapulmonary tuberculosis? The guideline says that there is no uniform guidelines. For the lymph node TB, pleural TB, abdominal TB, only 6 months of treatment. Only TB meningitis, there is 9 months to 1 year. There is no routine usage of corticosteroids in the case of pleural TB. Initially, we used to give 0.5 to 1 mg of corticosteroids. Right now, there is no routine indications. So meningitis, 9 months to 1 year. All other cases, lymph node, abdominal, pleural TB, only 6 months of treatment. There is no extension of the IP period, only 2 months of IP and 4 months of CP. So what are the challenges we come across as a physicians? Try to initiate insulin in the case of the uncontrolled hyperglycemia. If it is more than 9.5 HbA1c and more than 350 of random blood sugar, patient mostly won't accept the insulin because drug interaction, we should tell the interactions and other side effects. Try to use the short-acting sulfonylureas and gliptins if possible, like sitagliptin and other gliptins. There should be a renal modification in the case of kidney failure because both pyrazinamide and ethambutol can cause some kind of toxicity. We can avoid the ethambutol if possible. We can have a off dosage of ethambutol. And if you want to conclude that 25 mg of pyrazinamide alternate days, 15 mg of pyrazinamide and daily dosage. That means routine dosage you can give alternate dosage and 50 mg per kg for the daily dosage. You should aware of the IRIS, that is immune reconstitution inflammatory syndrome in HIV. It's nothing but a paradoxical reaction. We will see in the next slide. You should have a drug re-challenge in the case of jaundice and hepatic failure. The hepatic failure patients, if you want to introduce the ATT, you can go for SCO regimen, that is streptomycin, ethambutol, and ofloxacin. So DILI means drug-induced liver injury. It's almost the incidence of 2 to 28%. It is more common in the alcohol, high doses of INH, pyrazinamide, and other comorbid conditions, and extrapulmonary tuberculosis. So what are the classical signs of tuberculosis? We should have fluffy shadows, airspace opacities, thick walled cavity, miliary mottling, mediastinal lymphadenopathy, pleural effusion. That means active tuberculosis. So fluffy shadows, thick walled cavity, mottling, and lymphadenopathy. If you have a central lobular nodules and train bed appearance, that may not be always of tuberculosis. It can be some other cause like aspiration pneumonia, bronchiolitis, obliterating pneumonia. That means BOOP and COOP. It can be because of pulmonary edema and hemorrhages. So that may not be always tuberculosis. In the case of HIV population, we do have a lot of atypical presentations. It may not be in upper lobe, it may be in lower lobe. Try to aware of that atypical presentation of HIV. We'll call it as HIV and TB means, and diabetes means triple trouble. So diabetes and TB means double trouble. If there is both pleural and parenchymal lesion, just always think of immunodeficiency and HIV in the case of infection actually. So coming to the role of steroids and the role of surgery in the case of extrapulmonary tuberculosis. In the case of pericarditis, tuberculosis, meningitis, and pericardial effusion, there is only indication of steroids. There is no other indication of steroids. Surgery will be useful in the case of pericarditis, hydrocephalus, GI TB strictures and large residual TB-ovarian masses. So what is iris? Iris means immune reconstitution inflammatory syndrome. So diagnosis of exclusion. So first to suspect the iris if there is more lymphocytes count and tuberculin conversion, if there is an initial period of ATT, especially more common in the HIV population, first 3 weeks to 4 months of treatment. Mostly self-limiting, don't stop the ATT, try to have NSAIDs and other conservative managements. Important parcel of the routine management actually, iris. So what is meant by drug resistance? If you have any one of isoniazid acid, pyrazinamide, ethambutol, that means monoresistance. If it is more than one of isoniazid acid, pyrazinamide, ethambutol, that means polyresistance. But if it is resistant to the rifampicin alone, that means rifampicin resistance. HNR plus one of the fluoroquivalents means pre-XDR. HNR means MDR, HR and fluoro plus either bedaquiline or linezolid, that means XDR. So what are the various regimens options available for various drug-resistant tuberculosis? Right now we are following the latest regimen is BPAL-M regimen, that is bedaquiline, pyrrolizumab, linezolid, moxifloxacin in the selected population. So we do have a short oral MDR regimen for the 9 to 11 months. Longer MDR regimen for the 18-20 months in the case of leoflox, bedaquiline, linezolid, clofazimine and cycloserine. There is no CP or IP, just continue all the 5 drugs for the 20 months. In selected patient of isoniazid resistance cases, we can have a 6 to 9 months of the course. We can avoid the isoniazid, we can have a leoflox, rifampicin, pyrazinamide and ethambutol in the case of isoniazid resistance. This is a BPAL-M regimen. So bedaquiline, first 2 weeks, 4 mg OD. Next, from 3rd week to the 26 weeks, we can have a 200 mg 3 times a day. Pyrrolizumab, 200 mg OD for the continuous 26 to 39 weeks. Linezolid, 600 mg OD. Moxifloxacin, 400 mg OD. The contraindications are less than 14 years, we cannot use the BPAL-M regimen. In the case of pregnancy, lactation, and severe extrapulmonary tuberculosis, other cases, we cannot use the BPAL-M regimen. So try to use whenever indication is available, like more than 14 years, non-pregnant patients. This approach of integrated diagnostic and algorithm for both drug susceptible and drug resistant tuberculosis. If the MTB detected resistance means if it is more than 14 years, you can go for BPAL-M regimen, that is bedaquiline, pyrrolizumab, linezolid, and moxifloxacin. If less than 14 years means you can go for either short oral regimen of 6 months of bedaquiline, leoflox, linezolid, clofazimine, pyrazinamide, ethambutol, high dose INH, 5 months of leoflox, clofazimine, pyrazinamide, ethambutol. Otherwise, you can go for longer regimen of 22 months of. If there is isoniazid resistance, we can go for 9 months of the leoflox, rifampicin, and other drugs actually. Just want to have 3 to 4 case scenarios. This patient came to me with a history of unexplained cough for more than 2 to 3 months almost. He itself diagnosed a case of GRD, lot of other drugs. Came to me that HbA1c found to be 11.5 and random sugar around 350. You can have a cavity and fluffy shadows in the right upper lobe. CT was taken and he was started on 5 FDC. Right now he is doing very well. This patient actually treated by me. Right now he is in Tambaram Sanatorium in the Stanley Hospital. You can have this is called a triple trouble. It means both PLHA positivity, diabetes, and multi-resistant tuberculosis. We can see the cachexia and other complete destroyed lung, both the traction bronchiectasis and fibrothorax. So another interesting case, a 14-year-old girl with a history of 14 days of fever, high-grade temperature, chills and rigor, vomiting, left hypochondrial pain. On investigations found to be anemia, leukopenia, and thrombocytopenia. So LFT shows mild transaminitis. FLP showed that increased hypertriglycerides. X-ray shows X-ray chest was normal and used abdomen was taken. Spleen suggestive of the granuloma. You can see the somewhat granuloma. Sorry for the poor quality. His X-ray is almost normal, but spleen ultrasound shows that it's multiple hypoechoic lesions. That is the granuloma. So user-guided aspiration was done from spleen and sent for cytology. CB nat of splenic aspirate came positive for MTB, reform sensitive. Bone marrow biopsy was taken. This is actually the case of splenic tuberculosis with the secondary HLS. That means history of hemophagocytic lymphohistiocytosis. For that, there should be at least 5 criteria should be present out of 8. In this, our patients had a fever, cytopenia, splenomegaly, hypertriglyceridemia, and increased ferritin levels. He was started on ATT, and right now he's doing very well actually. So another case came with the history of PTB defaulter with the miliary TB, which is suggestive of acute sinus infection with all the regimens of antivirals and dexamethasone are started. You can see the multiple tuberculomas. So T1 iso intense and T2 hyper intense. In the case of involving the bilateral vascular edema, the midline shift, we can see that. So final key points are TB is one of the most important, greatest masquerade. It can mimic like anything in the body, except pregnancy. There is one great saying in the book, it can mimic like anything in the body. TB doesn't affect the pancreas, skeletal muscles and myocardium, and thyroid gland. Otherwise, each and every part of the body can be affected by tuberculosis. Try to get the bacteriological confirmation as much as possible. Don't start the steroids unless you are rolling out active tuberculosis. Pleural fluid CB is less sensitive. Don't exclude TB meningitis if CSF CB is negative. First 2 weeks of treatment is very crucial because that is the most infective period. Don't use unnecessary antibiotics in the form of augmentin, amoxicillin, clavulanic acid, linezolid, and moxifloxacin because each and every drug is having the anti-TB effects. Do LPA and DST if there is no response to the proper treatment. Don't do CB for the follow because dead bacilli can go for amplification, can mimic as sputum positivity. Okay, just avoid the sputum gene expert as a follow-up. Thank you for the patient listening.
Thank you for our excellent talk on tuberculosis and also about the NETP. So this has to be achieved within another 5 years. I like to know still you are following in cases of the meningitis, looking for the cobweb we used to do in our student days in the ward itself.
Still is a gold standard, sir. Still is a gold standard. Yes, yes,
It's a
sir.
gold standard.
Yes, sir. Definitely, sir.
So that doesn't need any other further investigations. We use, if we are able to find the cobweb, we will start away directly all the ATTs that was available at that time, streptomycin, isoniazid and other things. Later only came all these rifampicin and pyrazine.
Yes, sir.
Any other questions?
A patient diagnosed to have HIV and tuberculosis. I mean, he comes for HIV, but tuberculosis is incidentally diagnosed. How long should we wait before starting him on anti-HIV drugs?
So before, you used to start ART for the less than CD4 200, sir, we used to start. Right now, diagnosis of TB is initiation of TB, sir, actually. If you diagnose tuberculosis, right now we can start the ATT. To avoid the pill burden, we can start the ATT first. After 2 to 6 weeks, we can start the ARTs. That's right now, there's no time lapse. Only you can, at the time of diagnosis, you can start, sir. Simultaneously, sir. No need to wait for that, actually. You'll have a lot of atypical presentations, sir. Sputum negativity and pleural effusion and other less cavity and less sputum positive. Yes, sir. Everybody saying that half of diabetic patients having tuberculosis right now. One of the Kerala trials shows that 40 patients of diabetes of tuberculosis right now, sir. Diabetes have a 3 to 4 times increased risk of tuberculosis. Diabetes, yeah. So every TB patient you should check the diabetes and HIV. In HIV population, sir. Yes. Yes, sir. Yes, sir. So previously we won't do a resistance for the isoniazid, ma'am. Right now we are doing it for both rifampicin and isoniazid. If it is not responding, we can go for second line drug sensitivity. That is called DST, LPA. If possible, you can start the right drugs for the right patient. Yeah, we can restart, ma'am, no issue. The current guideline says that no need to continue the IP. Directly, we can first 2 months and then next 4 months, actually. So if there is no response to proper first line drugs, we can go for second line sensitivity, like other drugs. If there is strong clinical suspicion, we can start the ATT, ma'am. There is no lymphoma, there is no cancer, we can start. Otherwise, we can start. There is no nothing harm in that. Yes, sir. So in Stanley, right now we are having, after 1 month of ATT, some patients having the kind of severe drug-induced liver injury. The only thing is we can reintroduce, sir. We can reintroduce, pyrazinamide should be the last option. You can have isoniazid, then rifampicin, and then after last time you can have a pyrazinamide, sir. Still, it's more common in alcoholic, other comorbid conditions and other severe form of extrapulmonary tuberculosis, sir. So most of the patients developed within 1 week to 10 days, actually. Right now, my observation in Stanley, after 1 week they are developing, sir. Severe form of DLI. There's no diagnostic criteria. We can start the SU regimen. Right now, we are not using the streptomycin. We can have a low flux ethambutol, sir, right now. There's no diagnostic criteria, sir, actually. Everything should be individualized. See, if you test adult business, there's a lot of vaccine in the pipelines, actually, right now. If you test Manto, it will be positive for everybody, adult patients, actually. If you go and test in the low prevalence countries like UK and US, it will be more useful. Right now, we are following in the younger populations, less than 12 years, pediatric population. It's in that pipeline, sir. I think hopefully very soon it will get, actually. Thank you, sir. Thank you.
May I request our chairpersons to kindly present a memento to Dr. RBS Manian as a token of appreciation. We now request the chairpersons to felicitate Dr. Radhakrishnan with a memento. We also request the chairpersons to kindly present a memento to Dr. A.R. Balamurugan. I invite Dr. Ilongovan to offer a memento to our respected chairpersons. We also request our chairpersons to kindly present on stage. Thank you for your valuable contribution. We appreciate all the input shared. Let's now proceed to the next session.
Let's move on to the session Practice Corner. We are all privileged to have with us chairperson for this session, Dr. K. Lavanya from Tirunelveli, Dr. S. Priyadarshini from Salem, Dr. Soundarya Rajan. Sundara Rajan. It is our pleasure to welcome Dr. Meena Kumari from Tirunelveli to present on the topic Common Plant Poisoning.
Good morning, all of you. First of all, I would like to thank APA Velu for giving me this opportunity. Topic given to me is common plant poisons. So, though a very common scenario in medical ICUs and emergency department, in this presentation, let us have some insights in the diagnostic and management aspects in handling plant poisons. So, a quick intro into the topic. In India, poisoning ranks 4th among the common causes of death. Its fatality rate is 30%, and the plant poisoning is next only to pesticide poisoning. This is a study we performed in Tirunelveli Medical College on the epidemiological and clinical profile of various plant poisons in South Tamil Nadu. So, we concluded that pesticide poisoning is the first one, followed by plant poisoning. It is very commonly prevalent in the environment, so it is a favorite for female population to have a plant poison. So, in South Tamil Nadu, oleander is the most common plant poison, followed by datura and glory lily. Here in South Tamil Nadu, we don't get Clystanthes cholinus poisoning. It is in contrast to the studies from other parts of Tamil Nadu, especially northern Tamil Nadu, like this one from Vellore, which says that Clystanthes cholinus accounts up to 77% of poisoning, followed by oleander. This is due to the geographical distribution of the plant. We don't get Clystanthes in our region. So, it is wise to apply toxidromic approach as we do in any other poison. So, the plant poisons present as any of these following toxidromes, like an anticholinergic, cholinergic, some are cardiotoxic, neurotoxic or cytotoxic, and they can be a GA or hepatotoxic. So, while seeing a case, we must also take into account the background toxicological scenario, whether it is an acute intoxication or a chronic poisoning. We have to also see whether it is a highly toxic poison or a less toxic one, and also take into consideration whether there is any history of substance abuse. So, management overview of all the poisons, we have to start with gastric lavage and activated charcoal. Some of the plant poisons behave like a toxic time bomb, like the ones like oleander and oduan. They have a delayed gastric emptying time or prolonged intestinal transit time. They will produce their toxicity for as long as 72 hours. Because we have a lack of availability of appropriate antidotes in the periphery, and some of the plant toxins are very highly toxic, we have to apply multi-dose activated charcoal. So, this is very important in plant poisons, and they act by gut dialysis. They also interrupt the enterohepatic circulation. So, starting with oleander poison, most of the pictures I have taken in my neighborhood only. This picture is taken in front of my house, very widely available plant poisons. So, we have pink oleander or nerium oleander and yellow oleanders. The toxins are oleandrin, nereoside and thevitin. Here the oleandrin inhibits the Na plus K plus ATPase in the cell membrane and results in increased concentration of calcium and sodium inside the cells. It also increases the serum potassium levels. So, yellow oleander is more poisonous. All parts of the plants are poisonous, and the fatal dose is 8 to 10 seeds and 5 to 10 leaves. The toxicity ranges from mild GI symptoms and subtle STT changes to first degree AV blocks, sinus bradycardia, sixth sinus syndrome, and the severity increases, the patient develops advanced heart blocks and ventricular fibrillation. But the common ECG changes are ventricular ectopics and junctional rhythms. So, this is bidirectional VT, which is very characteristic of oleander poisoning. And treatment, as already emphasized, we have to give multi-dose activated charcoal and have to do continuous cardiac monitoring for 72 hours. So, other treatments are only symptomatic. For bradycardia, we give tablet orsiprenalin or atropine. For complete heart block, we have to give isoprenaline or temporary pacing. And for ventricular arrhythmias, we have to give injection lignocaine or fosphenytoin. So, one word of caution for treatment of hyperkalemia in the setting of oleander poisoning, we should avoid calcium gluconate or calcium chloride because of the presence of hypercalcemia per se in the setting of oleander poisoning. We can proceed with other treatment like glucose insulin infusions. So, there is a specific antidote, that is the digoxin specific FAB fragment, which is indicated in ventricular arrhythmias or hemodynamically unstable bradyarrhythmias, and when there is severe hyperkalemia with toxic digoxin levels. So, to conclude regarding oleander poisoning, it has high mortality rate up to 10%. So, let us go to the next case and discuss as a case scenario. A 35 years old female who had consumed leaf decoction, she presented with sweating, salivation and bradycardia. Her ECG shows the following one. So, this is hypokalemia. So, hypokalemia and cholinergic features. The diagnosis is Clystanthes cholinus, yes, or otherwise Odovanthalae poisoning. So, the toxins are diethylene and clystanthins, which deplete the glutathione and ATPases in the tissues. They are cytotoxic and cause GA upset, hepatic and renal failure. It inhibits the H plus ATPase in the renal brush border, thereby resulting in distal renal tubular acidosis and severe hypokalemia. Apart from the cholinergic features, it also produces neuromuscular weakness, a picture similar to myasthenia gravis, and it may also result in altered sensorium. So, N-acetylcysteine is the antidote, and hypokalemia is treated with IV KCl, bradycardia with atropine and temporary pacing, acidosis with appropriate doses of soda bicarb. What are all the mortality predictors? Consuming a boiled decoction of the leaves or consuming more than 60 leaves, and the presence of severe hypokalemia and presence of distributive shock and ARDS predict mortality. So, concluding remarks on Odovanthalae, it has very high mortality up to 40%, and death occurs within 3 to 7 days. So, let us go to the third case. A 68 years old lady. She was brought by her husband with history of consumption of herbal remedy for knee pain. That old man said that his wife consumed Anjal Aluppu Marundu. He was not sure what she consumed. And followed by that, throughout the night, the lady developed vomiting and epigastric pain. She landed up in the ER early morning. She was delirious, dehydrated and febrile, and the heart rate was 130 per minute, dilated pupils was present and bladder was full. So, this was the diagnostic clue. So, toxidromic approach, CNS agitated simulant features with anticholinergic toxidrome. So, the probable diagnosis is Datura poisoning, and she regained sensorium after giving lorazepam, and she admitted to have consumed one full fruit of Datura. So, atropine, hyoscine, scopolamine are all muscarinic blockers. All parts are toxic. The fatal dose is 100 seeds, but one Datura fruit itself contains more than 400 seeds. So, this is the features of Datura poisoning. It results in dry mouth, dysphagia, dilated pupils, delirium and hallucinations are common. So, physostigmine is the antidote of choice, which is indicated in hallucinations and agitations, hemodynamically unstable arrhythmias and refractory seizures. So, Datura also has high mortality rate, but if they present early, the mortality rate is only 2%. So, case 4 is mushroom poisoning, a very popular street food liked by young people. So, among the lethal mushrooms, Amanita phalloides is a notorious one causing poisoning. The phallotoxins and amatoxins inhibit the RNA polymerase II, and it leads to cell death. It is cytotoxic to liver, intestine, kidney and CNS. So, it produces profuse watery diarrhea, liver failure and renal failure. Death may occur in 3 to 7 days. It has a variety of toxidromes depending upon the species, and prothrombin time is a good prognostic indicator, and usually treated symptomatically with the fluid and electrolyte correction. Others are only some use of penicillin, silibinin and N-acetylcysteine can also be tried. That mortality rate is up to 20% in severe mushroom poisoning. So, some species like Inosae present as OP poisoning with muscarinic symptoms. In such cases, we have to treat with atropine or glycopyrrolate. So, let us go to the next case. He was a 21-year-old male presented to emergency room with history of vomiting, abdominal pain, giddiness immediately after consuming alcohol. That is within 15 minutes of consuming alcohol. Surprisingly, cops were also available in the ER because they were afraid whether he consumed methanol. So on arrival, he was disoriented, agitated, and conjunctival congestion was present. Tremors were present, pupils were fully dilated, and tachycardia was present. So we were not aware what he consumed, and as the patient was agitated, he was given benzodiazepines. So suspected a CNS stimulant, and after 6 hours, the patient became normal like any other person, and he admitted to the consumption of cannabis sativa, that is ganja, because the chronology and the clinical features did not tally with alcohol intoxication or alcohol withdrawal. So whenever ganja does not produce any highly toxic effects, and we do not have any patients landing up in ER after consuming ganja, only if they co-ingest with some other alcohol or something, they will land up in ER. So this is cannabis sativa. The dried flowering tops are called ganja and smoke, or they are smoked as dope or joint. The toxins are tetrahydrocannabinol and cannabidiol. So surprisingly, the prevalence of cannabis use itself is 3% in the population. This is the survey released by Ministry of Social Welfare. So such is the use of cannabis available both in rural and urban areas. The patient feels high, happy, relaxed, hallucinations are present. So these are all the psychological features, and there are some physical features also, like tachycardia, increased appetite. They develop postural hypotension like our patient presented. And the diagnosis is usually not necessary except in cases of medico-legal aspects, or they are used in dope tests for athletes. So treatment is symptomatic, there is no specific antidote, and the CNS agitation is treated with lorazepam, and psychotic features are treated with haloperidol. Suppose if they land up in coma, then we have to try with flumazenil. So next similar one is cocaine, obtained from the plant Erythroxylon coca, otherwise called coke. They present with tachycardia and hypertension importantly. So during the first hour, there is a very high risk of developing cerebral hemorrhage and myocardial infarction. It is also a CNS stimulant, followed by there will be depression. Treatment is symptomatic again, and hypertension is treated with labetalol, and CNS effects are treated with lorazepam and haloperidol. So to conclude regarding the CNS stimulants, cannabis and cocaine both are not so toxic. They are less toxic plant poisons, and there is psychic dependence only. There is no physical dependence or no withdrawal symptoms. So the last one is Gloriosa superba, otherwise called flame lily or glory lily. In Tamil we call it as a Changandal flower. This is a state flower of Tamil Nadu. It is cultivated in Tirunelveli and Sankarankovil areas for the tubers. They are exported for the anti-inflammatory properties, and it is very popular among the females. They consume the roots and come, and the roots contain colchicine and gloriosin. They are powerful mitotic inhibitors which disrupt the cell division. So this is a cytotoxic poison and result in GI toxicity, liver and kidney failure. It may also result in pancytopenia due to bone marrow suppression. Treatment is usually supportive, but the mortality rate is up to 15%. So a slight remark on the neurotoxic street side plant poisons. The first one is Strychnus nux vomica, and the next one is Calotropis, and the others are toxalbumins, that is Abrus precatorius and Ricinus communis. So to summarize, when a patient present with hypotension and bradycardia, suspect cardiac glycosides, Oduvan and mushroom present as cholinergic toxidrome, Datura as anticholinergic toxidrome, cannabis and cocaine with CNS stimulant effects, Oduvan, mushroom and gloriosa are all cytotoxins. They present as multi-organ dysfunction syndrome, and there are some neurotoxins also. So take home message, again I emphasize on the use of multi-dose activated charcoal, and there will not be any difficulty in treating a plant poison except if the patient arrives in the ER in an inebriated state, or if the patient is a geriatric or pediatric patient, and if he had consumed some substance. So it is wise to apply toxidromic approach in poison identification and manage the patient appropriately. Thank you for your patient listening. Once again, I thank APA Velur for giving me this opportunity. Thank you so much.
That's an excellent presentation, madam. You have talked about all the plant poisoning. Though there are many plant poisonings, oleander is the commonest plant poison come around. Every part of the plant is poisonous, as I already told you. but the seeds are more poisonous. But mushrooms are, many people are, we take, but some of the mushrooms are poisonous. You said the penicillin J is effective. How it's what's the mechanism of action?
It prevents the binding of the amatoxins to the hepatocellular competitively binds with the amatoxins and prevents its action on the liver cells, prevents the hepatic failure.
Any questions?
Leaves are more poisonous than seeds. Six leaves are more poisonous.
It depends upon the grams, sir. Seeds are more poisonous. Seeds are more poisonous, sir. The crushed seeds are more poisonous.
Mentioned 6 leaves are sufficient.
5 to 10 leaves, sir. Ama, sir. Thank you, sir.
We do not know about NS-style system. We get lot of Oduvanthalai in Vellore Medical College. Those days, most of the patients, they died. The percentage of this is 70%, we can say more than 70%. But we don't use NS-style system. Said it's NS-style system as the antidote.
I have no experience in giving N-acetylcysteine for Oduvanthalai, ma'am. But literature says that use of N-acetylcysteine as a free radical scavenger.
So still we are not able to do much for the Oduvanthalai person.
Yes, ma'am.
Because we tried to do and study with the CMC, but that also was not fruitful. Because they said that is some problem in the endothelium. Something happens. That's why there is a potassium hypokalemia.
Yes, ma'am.
But that's why I wanted to ask. You said it's antidote test. Thank you.
Thank you, ma'am.
It's a very nice presentation by Dr. Meena Kumari.
Thank you,
In the
sir.
southern Tamil Nadu, this oleander, datura, and this glory lily, that is Bengal. These are the common poison in Tamil Nadu, southern part of Tamil Nadu, especially in datura. So previously it was known as the stupefying poison, as it was used by the thieves in the train rail journey. They will add the powder of the seeds with the tea, and they will give it to the fellow passenger. They will become delirious, and they will take the money or something from the fellow passenger, and they will run away. He will be delirious, and he does not know what has happened. So it is called stupefying poison. And this yellow oleander is very common in the area. That is Tangarali. They will call this Tangarali. Not this roadside la இப்போ வச்சிருக்காங்க அந்த இது இல்லை. It will grow like a tree, small tree. That is Tangarali. That is the yellow oleander. So as she told, it is poisonous in all parts of the plant is poisonous.
Thank you.
Thank you, ma'am, for such a nice presentation. Thank you.
Thank you, ma'am.
Let me move on to the next session. May I invite Dr. Audrey from Vellore to take a lecture on early recognition of maternal sepsis.
Okay, so today morning I'll be speaking about early recognition of sepsis in pregnancy. Why I'm talking about this is one of the most irritating and scary consults is when the obstetricians call you saying there's a sick pregnant patient, how do I deal with that? And so we are part of the obstetric medicine unit where we are a medicine unit which deals with medical problems in pregnancy. I need my slides. So what I'll be talking about is the burden of maternal sepsis and its related deaths in India, pathophysiology, screening for sepsis in pregnancy, causes of maternal infections, early management. So maternal sepsis is a life-threatening condition, and it's caused by organ dysfunctions resulting from infections in pregnancy, childbirth, post-abortion, postpartum period. And there's a study which looked at all the maternal deaths in India from 1970 till 2020, and there were almost 1.3 million deaths in India, and 2/3 of those were in those red states which you see. And The problem with this is most of these deaths were in very young women, 20 to 30 years old. And when we looked at the causes of death among these patients, the most, around 10% of these deaths were because of sepsis all over India. And in Tamil Nadu, Maharashtra and Kerala, it was around 8.2%. So when we look at the epidemiological triad, which we look for every disease that we do, here the host is a little different. Here the host is a pregnant woman, along with the slightly different environment where the person moves from most of the times the pregnant woman goes from her husband's house to the mother's house. And the agents are also a little bit different, which I'll come to. When we talk about the host factors, you should realize that there are a lot of physiological changes which take place in pregnancy, which make diagnosis of sepsis a little bit more different than how it is in a non-pregnant woman. The peripheral vascular resistance is down, the heart rate goes up, the arterial pressure comes down, the cardiac output increases. All of this can mask the initial signs of sepsis, which we normally identify. There's also the hypoxia is more rapid in onset because the plasma volume is more, the RBC volume is more. There is decreased FVC because of the gravid uterus, reducing the amount of the diaphragm can expand. There is increased renal outflow, GFR goes up. So the creatinine, what we normally take 1.4, even a creatinine of 1 is abnormal in a pregnant woman. So these are things which can affect diagnosis of sepsis early in a pregnant woman. They have a higher risk of thrombosis and DIC, more risk of aspiration pneumonia because of the lax lower esophageal sphincter. So there are a lot of physiological changes which can mask the diagnosis of sepsis in a pregnant woman. So we all know this SIRS going to sepsis, to severe sepsis, to septic shock. But the problem is as we go from one step to the other, the mortality keeps increasing. With just SRS mortality of around 2.1% to severe septic shock where the mortality goes up as high as 28% in pregnancy. So it is very important to pick it early in the SIRS stage itself rather than letting it progress lower down the order. So when you have a healthy pregnancy, so initially they have a mild deterioration, then progress to severe illness, and this can lead to death or adverse outcome. So most of our early warning systems are to pick up the pregnant woman in that mild deterioration stage. So if you pick up there, then you prevent them from progressing lower down. So it helps you to identify early and prevent severe illness and death. So some caveats when you're dealing with a pregnant patient. First is, these are young women, right? They are 20 years old, 30 years old. And so they have a very high tolerance. So they might look well when you, normally when you look at your patient, say, oh, this patient looks sick. That doesn't hold true with a pregnant woman. They might look well till they reach the very end of their compensation and then they collapse straight away. So very common thing we hear in labor room is, nalla irundanga, bathroom ponanga, she collapsed there. It's a very common history which we hear. Because they compensate very well till they reach that end point and then they collapse straight away there. So it is very early, important to pick this up early. So always count, don't just visualize them, count the heart rate, count the respiratory rate, check the BP. Normals are little different in physiological cases, physiology in pregnancy. Fever may or may not be present. You might not have a patient who has fever. And the other caveat is if they are on epidural for the pain relief, they can have fever which might not be related to sepsis. For shock, you need to measure lactates, urine output, fetal heart rate, which are other things extra which we need to do. And the gravid uterus affects resuscitation. It can reduce the cardiac output. It can cause problems with ventilation. It can cause problem with the venous return. And when you give the antibiotics also, the dose, because there is a higher volume which you need, the absorption is different, the excretion is different, metabolism is different. So you might need a higher dose of the same antibiotic too. So when we look at screening for sepsis, the normal SIRS criteria is temperature more than 38, heart rate more than 90, respiratory rate more than 20, and WBC count more than 1200 or 12,000 or less than 4,000. It's little different in pregnancy. Here the heart rate cutoff becomes 120 rather than 90, and the WBC cutoff becomes 14,000 compared to 12,000. It's slightly different because during labor the WBC counts go up and the heart rate also goes up because of the physiological changes. So there are some early warning scores. So what we use for any pregnant woman who comes, we use these early warning scores so that we pick deterioration early. So there are a lot of scores which are used. Normally for non-pregnant patients we use SIRS or Q-SOFA score. There's something called obstetrically modified Q-SOFA score. This is the last one which I've talked about, OM Q-SOFA, where you need 2 or more of any of these. Respiratory rate for Q-SOFA is 22, here it becomes 25. Systolic BP is 100 for Q-SOFA, here it becomes 90, and alternation remains here. The one which we commonly use is something called MEWS, Maternal Early Warning Score. So here you have every time the sister goes for round, she notes down these parameters: respiratory rate, saturation, temperature, BP, diastolic BP, heart rate, and neurological response. So here, this was brought about for when the nurses should call the doctor immediately. So when you have one yellow alert, you can recheck after 30 minutes. But if you have 2 yellow or 1 red, you should immediately inform the doctor at the time. And if it's more than 2 yellow or 2 reds, then that needs an urgent intervention at that time. So this score has sensitivity of around 40 to 100% with specificity of 4 to 97%. This was mainly made for chorioamnitis, sepsis secondary to chorioamnitis in pregnancy. There are other scores also, like the modified obstetric early warning score. This is also similar, where it uses heart rate, systolic BP, respiratory rate, temperature, saturation, and mental states. Here, if the score is 4 to 5, you can wait and watch, but if a score more than 5 needs ICU admission. The gold standard for diagnosing sepsis in pregnancy is the SOS score, or sepsis in obstetric score. Here, along with the clinical parameters, you also include WBC count, percentage of immature lymph neutrophils, and lactic acid. So this score, if it's more than 6, the incidence of ICU admission was around 16%, score less than 6 was only 0.1%. So this is for most of the, it's a good specificity, but it's not a good screening test. For screening test, we use the early warning scores, but this is to say whether the patient has sepsis or not. And when we looked at, just comparing the SOS score with the MEWS score, where score has very good specificity, whereas the MEWS score has very good sensitivity, but both of them have very good negative predictive value. So there are some things which we still not clear about. One is, when should we check this? At admission, when the patient is having fever, when the nurse calls us, the timing of when this course should be done, that is not very clear. How frequently should we check is not clear. It's mainly determined by the yellow alerts or red alerts which you find. Anemia can impact these scores. Whenever you have anemia, the scores become less sensitive specific. And if the patient is on beta blockers, or they are given steroids for the lung maturity, or if they are on NSAIDs for pain relief, all these can affect the score. So these are some things which you need to keep in mind whenever you're doing this scoring. So there are a lot of risk factors which predispose a pregnant woman to develop sepsis. And this was a confidential inquiry in US. They found that obesity, diabetes, immunosuppression, anemia, vaginal discharge, pelvic infections, all of these are risk factors for developing sepsis in a pregnant woman. So broadly, we classify sepsis in pregnancy in these 4 categories. One is whether it's related to pregnancy or pregnancy-associated procedures, things like chorioamnitis, episiotomy, wound getting infected, the LSCS size getting infected, septic abortion, puerperal sepsis. All of these are sepsis related to pregnancy. The second thing is things which are not related to pregnancy but are more common in pregnancy. Things like pyelonephritis, lower respiratory tract infection, malaria, listeria, viral hepatitis E. These are not related to pregnancy but are more common. Third things are normal infections which we see in non-pregnant people. Pregnant women are also equally susceptible for those, like our pneumonias, scrub typhus, dengue, all of those. And finally, because they are in hospital, they are at a risk for developing hospital-acquired infections as well. So when a pregnant patient has sepsis, we need to see in which category she falls under, and to identify as based on that. And always remember, treat the mother. The only way you can save the baby is by saving the mother. Okay? Don't focus on the baby, treat the mother. Resuscitating the mother will resuscitate the fetus. If the source you think is intrauterine, then you need to deliver. You need to improve the functional intravascular volume and maintain adequate oxygenation and ventilation. Identify the source of the sepsis, and you need to address the septic foci. And empirical antibiotic therapy is recommended whenever you are suspecting sepsis in pregnancy. So things which we need to do, this is the sepsis bundle for pregnancy. So it's called 1 hour bundle, where in the first hour you take, as soon as you're suspecting sepsis, you take culture, send off lactic acid, start off broad spectrum antibiotics, resuscitate with crystalloid fluids and vasopressors, identify the source of sepsis, try to do ultrasound imaging to see if there's an intra-abdominal collection, chest x-ray with shield if you're suspecting lung infections, metabolic profile cultures. Then if you identify a source, you need to control the source, which may need, if it's a wound infection, you need to lay open the wound. If it's a collection, you need to aspirate it and deliver the fetus if it's an intrauterine this thing. You need to keep an eye on the fetus as well with the fetal heart rate monitoring. And if you're suspecting that you are going to deliver the mother early, you need to give off the steroids for fetal lung maturity. And you have to prevent complications like DVT, avoid high sugars, and early enteral feeding. So some of the challenges we feel is ensuring hemodynamics stability. So normally what happens is the uterus presses on the IVC. So whatever, if you have an IV line on the lower limb, your fluids will not reach. So I'll make sure you put the patient on the left lateral decubitus position in the 3rd trimester with a 30-degree lift. Lactates are a good measure, but remember that if they have hypotension, a serum lactate of more than 2 itself is significant. If the lactates are elevated, start off IV crystalloids, and vasopressors if they are not responding to initial fluid response. Always remember, in a pregnant woman, try to get an upper limb line rather than a lower limb line, because the uterus will compress the IVC and you will not get your fluids or your inotropes going in. And maintain a MAP of more than 65. Among the inotropes, norepinephrine is preferred. Maintain a MAP of 65. Even if you're using a invasive arterial monitoring, you make sure you use the upper limbs. And if it's not responding to norepinephrine, you can add vasopressin and adrenaline. And primary source control is very important. It starts with a complete detailed history and clinical examination. Take blood cultures. If there is a surgical source, you start get the source under control. Start off broad spectrum antibiotics. And depending on whether you're suspecting a community acquired versus a hospital acquired, your antibiotics will be different. Assess if they have had infections in the past. Look at the local antibiogram. And once you identify a source and you got your sensitivity, please de-escalate. Sometimes we keep the same antibiotic broad spectrum on, but as soon as you get the source and you get the sensitivity, de-escalate. Procalcitonin are not standardized in pregnant women, but you can use it as a serial procalcitonin markers to identify the response. But a single procalcitonin value is not helpful in pregnancy. And seasonal flu season, make sure you give antivirals as well. Okay, so these are some of the indications for ICU transfers: hypotension, pulmonary edema requiring dialysis, low sensorium, multi-organ failure. All of these are indications for ICU transfer. Okay, this is just a recap of the maternal early warning score and the sepsis 1 hour bundle, which I've gone through. Thank you.
Now the floor is open for discussion.
That's an excellent presentation, sir. You have stressed the importance of early recognition. Pregnancy is a physiological condition, but complication do arise at times. So you stress the importance of the early recognition from the prognostic point and the treatment points about the course. Any questions?
Is there any relevance to the serial assessment or the procalcitonin?
So procalcitonin, the problem is it's not been studied in a pregnant physiology. So whatever studies have been done, they have found variable response. Some people have found it useful, some people have not. So it's not standardized in pregnancy. So a single procalcitonin value does not help you. So if you say send a procalcitonin suspecting fever, procalcitonin is 3, it doesn't help me. But if I'm suspecting sepsis and I have an initial procalcitonin of 3, after 3 days I've started antibiotics and this repeat procalcitonin is 0.2. That helps me saying, okay, my therapy is working. Or if the procalcitonin after 3 days has become 10, then I need to say that, okay, I have not got source control, I have not treated adequately. So it helps in your assessment of your treatment response, but doesn't help you in diagnosing sepsis.
Hydroxychloroquine is primarily an antiparasitic, but it also controls bacteria infection. Depending upon the lyso
So the issue with HCQ is safe in HCQ is safe in pregnancy. The problem is the effect which you're talking about. The MIC required for that is 2.5 micromoles per, and that you need a very high dose. It's not the normal 400, 300, 400 which we use. To achieve that MIC, you need a dose of 1200. At that point, it becomes toxic. So to get that MIC, to get the antilysosomal effect, you need a very high dose of HCQ. The normal 400 does not have that effect. So at 400, it has a good anti-malarial effect, it has a good anti-inflammatory effect. But to get the antibacterial effect, the dose required will be at least 3 tablets at a time.
You had got 30 years ago. SCQ is anti-parasitic,
Yes.
not bacterial or viral. But now the Cure Foundation of India, they have contributed this particular point.
Yes. So it is.
There is a transferrin level, thereby inhibiting the sepsis.
Yes, but for that you need a higher dose of HCQ, not the normal 400. Yeah. Yeah, sure. Okay, sure. Yeah.
Thank you, sir. No further questions. We'll move on to the next topic, prudent use of NSAIDs. Cancelled. Okay.
Now
So,
I
next topic is not there. So, we'll
now I
conclude the
invite Dr. Chairpersons to present the momentum to Dr. Meena Kumari and Dr. Adrin. Now I invite Dr. Adrin to get a momentum. I request our core committee member Dr. A.S. Morgan from Tirunelveli to give momentum to chairpersons.
We are privileged to have with us Dr. Satish Kumar from Vellore and Dr. Meena Kumari from Tirunelveli as chairpersons for the session 4 Clinical Pulse. Now I invite Dr. Soundararaja from Melmarvattur to present on Rabies current scenario.
First of all, I thank the organizers for the opportunity given to me. My topic is this slide. Rabies current scenario. Slide. Okay, yeah. Okay. Rabies is a fatal disease
with nearly worldwide distribution caused by zoonotic neurotrophic virus. It is included in the neglected tropical disease roadmap of World Health Organization. Rabies is one of the oldest, best known and most feared human diseases and is one of the most serious public health problems. And rabies causes approximately 59,000 human deaths per year globally, out of which 20,000 are reported from India every year. Most of these deaths occur in Asia and Africa. Rabies present in all the parts of the continents except Australia and Antarctica. Other rabies-free countries are Japan, Malaysia, Bahrain, Oman, Great Britain, Spain and New Zealand. In India, rabies is reported in all areas except Andaman and Nicobar and Lakshadweep Islands. It mainly affects the rural population. Children are more commonly involved. And it belongs to the genus Lyssa virus, family Rhabdoviridae. And it is a bullet-shaped virus. It is composed of outer envelope with spike-like projections and internally helically packaged nucleocapsid, which ensures genomic transcription and replication. And the rabies virus travels in the nerves and is carried centripetally by the flow of oxoplasm to the dorsal root ganglion. It multiplies further the dorsal root ganglion and causes characteristic prodromal symptoms and paresthesia at the site of inoculation. From there, it travels to the brain where massive viral replication occurs. And the virus chain migrates along the efferent nerve to almost every organ such as adrenal medulla, cornea, pancreas, nerve tubule of hair follicles and salivary gland, leading to virus shedding in the saliva. It may also be shed in the milk and urine. It is a schematic representation of the pathogenesis. The pathology is mainly the hippocampus and the ganglia. There is severe congestion of the grey matter and white matter with perivascular mononuclear cell infiltration and polymorphic nuclear cells and lymphocytic foci. And PAPS nodules consist of glial cells are also described. Negro bodies, which are intracytoplasmic inclusion bodies, initially described by Adelche Nigre in 1903. Mainly present the pyramidal cells of hippocampus, Purkinje cells of cerebellum and medulla and various ganglia. And the humans are usually infected when virus-laden saliva is inoculated to the skin by the bite of the rabid animal, especially dog. Licks on abraded skin, even healthy mucosa by infected animals may produce rabies. Other modes of transmission include drinking of unboiled milk, which is very rare, and eating of uncooked meat of infected animals. Uncommonly, transmission occurs through inhalation of airborne rabies virus. But in bats, which is a mode of spread in United States, where inhalation can occur. So the human rabies virus has been reported after corneal transplantation. But there is a theoretical risk of transmission of rabies through contact with the patients, then their secretions may contain virus. But there is no documented cases are described because the secretions contain lesser amount of virus. So risk of infection depend upon the factors such as virulence of rabies strain, quantity of the virus deposited, site of the bite. The areas with close proximity to the brain and richly innervated areas are dangerous. So these are the common animals which transmit disease, commonly dogs, occasionally cats, monkeys, cattle, buffaloes, mongoose, foxes and the 2023. And the year 2023 we have 4.41 lakhs of cases and 2024 4.29 lakhs cases by different statistics sources give different statistics also. And district-wise data, Salem is 37,000, Tanjavur 24,000, Tiruchirappalli about 23,000, Pudukkottai 21, and Chennai 11,000, Coimbatore 14, and Madurai 12,000. The clinical features are quite variable. The incubation period ranges from 10 days to more than a year, but the average incubation period is 22 and 90 days. and tends to be started in case of bites on the face as against those on the limbs. The clinical manifestation may be in the prodromal stage or furious or paralytic phase. And the prodromal stage mainly constitutional symptoms will be there, and in addition there may be paresthesia and fasciculation around the bite. And the furious rabies, the patient can have excessive motor activity, agitation, hallucination, lacrimation, salivation, perspiration, muscle spasm, opisthotonus, seizures, and focal deficit. And there may be lucid intervals in between, and after that brain dysfunction will come. There may be diplopia, facial palsy, hydrophobia, aerophobia can occur. But dysarrhythmias can also occur. Involvement of the respiratory center will lead to apnea death. But you have to remember here they will be relatively conscious until death. And the paralytic rabies, there may be flaccid paralysis, and it may ascend symmetrically or asymmetrically. And then death occurs from the involvement of the respiratory center. And the rabies in animals, there can be two forms, frank rabies and dumb rabies. Frank rabies have 3 stages. First stage, the animal experiences personality reversion. It may avoid people or become more friendly than usual, appears distracted, becomes either unusually restless or quiet. Second stage, the animal wanders about avoiding familiar persons and becomes excitable. It bites any object in its path and barks repeatedly without any cause. And it develops a perverted appetite and swallows any object. And the stage is characterized by paralysis of the muscles and excessive salivation, convulsion, and hoarse or inaudible part. And the lower jaw may hang loose with a protruded tongue. And the animal becomes very weak, and the body is unable to support, the body becomes very weak. The dumb rabies, the animal is lethargic, and there can be tremors and complete paralysis can occur. These are the differential diagnosis, starting from Guillain-Barré syndrome, cerebral psychosis, and sometimes absorbing poisoning like that. And the laboratory diagnosis when the antemortem arrive, so where antigen can be detected in the corneal impression, and the multiple skin biopsies are taken to the nuclear area of the neck, where there is the hair follicles contain peripheral nerves, and the isolation of the virus can be done from the saliva or CSF. This is the table. Okay, postmortem diagnosis also fluorescent antibody technique you can do, and the virus can be isolated from the from mouse brain, inoculating the tissue interact. And the laboratory diagnosis, if it is, there may be direct, in general, the direct test and indirect test, the antigen detection by cellular staining, and then direct fluorescent antibody test, direct rapid immunohistochemistry test, rapid antigen detection test, and molecular methods where nucleic acid amplification test can be done, and mouse inoculation test can be done, and like that, and then ELISA also can be done. Okay. Now the treatment, once symptoms, only palliative treatment only can be given. Seizures can be controlled by diazepam, supplemented by chlorpromazine. So there are, after extensive treatments, there are few cases have been survived, but they have major neurological complications with the active immunization and passive immunization. But there is a Milwaukee protocol, though this is also aggressive therapy, where there is an induction of coma by combining the ketamine, midazolam, barbitrates, and the antiviral drugs like ribavirin, amantadine, interferon alpha, and intensive care along with the active and passive immunization. Tetanus toxoid and the antibiotics can be given as necessary. And but the main treatment is immediate treatment of the wound. Scrub the wound thoroughly with soap and water, and apply tincture and alcohol. Do not cauterize. Avoid suturing. Suppose the suturing is done, only secondary suturing can be done, because to prevent bleeding of that. Because when you suture, it can produce more trauma. That will help in penetration of virus to the deeper tissue. And this is the treatment mainly depends upon the category of the bite. The category 1 is touching or feeding of animals, and licks on intact skin, contact with the intact skin with secretions, and or excretion of rabid animal. And category 2, there is nibbling of uncovered skin, minor scratches or abrasions without bleeding. Category 3 is single or multiple transdermal bites and licks on the broken skin and contamination of the mucous membrane. So category 1, there may not be much needed unless wound management is only enough. The second category, there is a rabies vaccine is enough unless there is a immunocompromised patient. And category 3, an immunocompromised may need, in addition to the rabies vaccine, rabies immunoglobulin. This is the importance of the wound management. And then, say, when you do the washing with the running water with the washing, what happens is you are mechanically removing the virus. And the chemical treatment soap will inactivate the virus. And biologically, when you infiltrate rabies immunoglobulin, you are neutralizing the virus. So anti-rabies vaccine, we can wait for we can observe for the 10 days, but it may not be necessary because sometimes incubation is very short. So that time, without waiting for the 10 days, we can start the vaccine and 0, 3. Suppose the animal is alive, you can avoid the vaccine, but you can give, otherwise you can change into pre-exposure prophylaxis, being given a dose on 28 days. And then there are broader types of vaccine, include nervous tissue vaccine, which is a simple vaccine because it's not given nowadays because of the high risk of neuropathic effects. But the vaccine available are human diploid cell vaccine, purified sick embryo vaccine, purified vero cell vaccine, purified duck embryo vaccine. The passive immunization, the anti-rabies serum or immunoglobulin given, equine rabies immunoglobulin, if it's given 40 international per kg, human rabies immunoglobulin is 20 international per kg, and these will not cross the blood-brain barrier, so it will neutralize only peripherally. So, but rabies, human monoclonal anti-rabies, that is the dose is 3.33 internal units per kg, that can cross the blood-brain barrier, so it can act in central nervous system also. Then other monoclonal antibodies, murine monoclonal antibodies in the world, tocilizumab, mirocumab dose is about 40 international kg. So it can, because ERIG is heterogeneous, there may be some cases anaphylactic reaction. So it is anti-rabies vaccine given up to 7 days only. After that, it's not. It may interfere with the active immunization. And this is the post-exposure prophylaxis. Here the 5 doses are given. This is SN regime. That is about 0, 3, 7, 14 and 28 days. The 90th day is the optional, which is not pressed upon. This is the, so usually vaccine is given deltoid in children and anterolateral as per the thigh. Gluteal disease is avoided. But you cannot transfer from one mode of treatment, the IM to ID, or one type of vaccine to another type of vaccine. And then, so because of the cost effectiveness and feasibility, program feasibility, then the updated TOY Red Cross regime, there's the 4 doses are being given, and then there is that 0.1 ml dosage is only given. That is given on 0, 3 and 7 and 28. 14th day, there is no vaccine. And then, so after previously immunized people, when there is a dog bite, 0 and third day, the vaccine is begun intradermally, intravascularly. But within 3 months, dog bite is there, you can do. After that, you have to given as another schedule. Okay, this is now the WHO guidelines, the 2010-2018, slight difference is there. Now the 2018 guidelines, they have shortened the duration and duration of the treatment, and because the day which you give also slightly altered. And what are the treatment failures? The late reporting by the patients, improper or inadequate wound washing, application irritants to bite wounds, and suturing, and then non-administration of rabies immunoglobulin, and incomplete vaccination, like that. And pre-exposure prophylaxis, They are given to laboratory staff, veterinarians, animal handlers, wildlife wardens, travelers from rabies-free areas to rabies endemic areas. So this is given on 07, either 21 or 28 days is being given. This also that free exposure, there is a in 2008 guidelines, so that there is a shortened treatment they are talking. This is about the summary of the vaccine schedule, where how many injections you have to do, how many visits patients have to do. So how to prevent the dog bites, that is important. So know the body language of the dogs. Typical warning signs of unfriendly dogs are snarling, stiff stance and staring, ears laid back, lip retraction, fur hair on back standing up. Train pet dogs not to bite, and don't play aggressive games like wrestling or tug of war with pet dog. Do not stare at the dogs or provoke any animal. Don't leave children unattended with the dogs. Talk to your children about avoiding strange dogs and crawling dogs. Teach children not to take food or toys away from the dogs. Do not disturb the dogs that are nursing or sleeping. When the dogs in pain, they tend to bite by protect themselves. So those don't kick the dog and such type of dogs. Don't run fast a dog, because they naturally love to chase and catch things. So when they come bite, you stand there itself. Sometimes the dog may not get. When you run, there is possible to get bitten. And then there are two more vaccines. The Science Direct and Nature publication. And there are two more vaccines. They talk about the mRNA vaccine and self-replicating vaccines. Where the self-replicating vaccine, there's a phase 1 trial, the strong immune response with a single dose with a high tolerability, and the mRNA, other mRNA-based rabies vaccine, that is this encapsulated mRNA vaccine encoded a rabies virus glycoprotein. So it gives a rapid and long-term immune response. This is recently they talk about these vaccines. This is under trial, and now. So only the medical department or any other department will not control the dog bite. So that they have planned a One Health approach, that is a design and implement program and policies and make legislation research in all multiple sectors are involved. So that is then, so that the department involved, the health department, veterinary sectors, urban development, education, environment and wildlife, civic bodies, like that. Where you can do mass dog vaccination or dog birth control measures we can take. And the global strategic plan, WHO in December 2015, they want to reach a goal of 0 human rabies deaths by 2030, along with the collaboration of World Health Organization of Animal Health and Food and Agriculture Organization of United Nations and Global Alliance for Rabies Control. So, and to conclude, rabies is a fatal disease, but it can be vaccine preventable. Urgent action is required for the rising trend of the rabies cases on dog bites, necessitating immediate and coordinated effects. So success depends upon the combined efforts of government agencies, healthcare providers, and the communities. Thank you.
We'll have the discussion at the end of the talk, the session. The second speaker.
Thank you, sir. Now I invite Dr. Radha Vijayaraghavan from Chennai to speak on From Insight to Impact, Understanding Serum Creatinine Urine Examination and EGFR.
Move this. Good morning, everybody. Good morning to one and all. A warm welcome from Railways. My topic is Understanding Serum Creatinine, Urine Exam and EGFR. The theme of this conference is From Insight to Impact, Elevate Patient Care. So in the next few minutes, I will be talking on the salient features on the insights, impact, and how to translate it to a patient care. So one slide on the creatinine metabolism. The product is actually creatine. It is secreted by the kidney, liver, and pancreas into the blood, and it is taken up by the muscle, where the creatine is converted to phosphocreatine by creatine kinase. This creatine to phosphocreatine is a very important reaction which occurs in the muscle and is paired with ATP, ADP phosphorylation and dephosphorylation, and this is how the muscle derives its energy. So whenever ATP gets converted to ADP, the phosphorus is taken up by the creatine, converted to phosphocreatine. 1 to 2% of phosphocreatine is converted into creatinine, which is the waste product, and which is secreted by the muscle into the blood. Once the creatinine goes into the blood, it is taken up by the kidney, where it is filtered in the glomerulus. 100% of the creatinine in the blood is filtered by the glomerulus. There is no major tubular reabsorption. A very small percentage gets secreted from the tubule. So that is why the serum creatinine is a marker of renal function or the glomerular filtration rate, because majority is filtered by the glomerulus and very little is reabsorbed and a very little quantity is secreted. So serum creatinine is still the most available, cheapest and easy to measure marker of kidney function. Though we have other markers like cystatin, we've not started using it widely because of its less availability and cost. How does the serum creatinine measurement take place in the lab? These are basic things we should know. There are a few methods: the Jaffe method, the enzymatic method, HPLC, and the IDMS method. IDMS stands for isotope dilution mass spectrometry, and this is the best method recommended by KDIGO. However, IDMS is not available everywhere. It's a bit costlier. The commonest measurements are the Jaffe measurement or the enzymatic method. If we do not have IDMS, you should insist that the lab does an enzymatic method. The next best is Jaffe method. So whenever the serum creatinine is reported, you see by what method it was done and see the lab normal also. A good NABL accredited lab would give you the method by which it was estimated and what is their lab normal. There is a lot of in-person variability of creatinine up to 8%. We have seen patients telling my creatinine was 1.8 last time, now it is 1.7, because there is an in-person variability. And the serum creatinine results should always be interpreted in the clinical context. The same serum creatinine concentration may correspond to a vastly different eGFR in patients with different body composition. I will explain that subsequently in a slide. Serum creatinine is an inverse marker of eGFR. As the GFR goes down, the serum creatinine increases. So when we have an elevated serum creatinine, the patient comes, what are all the things we should see? There is something called a false increase in creatinine and a false decrease in creatinine. As the creatinine goes up, even the patients know, we know that there is something wrong in the kidney. But before that, before you start evaluating for renal things, you look at these. There can be a false elevation of creatinine because of a lab interference. The Jaffe assay has an interference because of high blood sugars and ketones. Delayed centrifugation. Whenever there is a high total protein like a myeloma or when there is hemolysis, there is an artificial elevation of creatinine which is actually not a renal failure. Similarly, when the enzymatic assay is done, high proteins and lidocaine, some drugs like even cephalosporins can produce a lab elevation of creatinine. This is not renal failure. Similarly, a high protein intake in the diet leads to a little bit marginal increase in creatine. Creatine supplementation, which is very common. People, youngsters go all the time to gym, they want a 4-pack ABS and all, and they are given lot of creatine supplements. Inadvertently, when they take them, the serum creatinine can go up. When there is a greater lean mass, athletics and bodybuilders have full muscle mass, and so their creatinine would be higher. This does not mean that they have renal failure. And certain drugs which inhibit the tubular secretion of creatinine produce an elevated serum creatinine. This is again not renal failure. Drugs are cimetidine, trimethoprim, salicylates, fenofibrate. We know many patients on fenofibrate coming with 1.7 creatinine, kidney workup is normal. False low creatinine can occur because of hyperbilirubinemia. So whenever we talk of jaundice, we know that the bilirubin can interfere with the creatinine estimation and produce a false low levels. Again, hemolysis can interfere. Low creatinine can occur when the gut takes over. We talked a lot about gut microbiome. Whenever the kidneys fail, the gut takes over. The gut microbiome can produce creatinine and can degrade the creatinine. So that can be contributory. Older patients who have less muscle mass have lesser creatinine, and patients who have extreme malnutrition and cachexia have low serum creatinine, and hemodilution also decreases the serum creatinine. These are all the various ways in which the creatinine gets altered, not by the glomerular filtration. Why is serum creatinine very important? Because the definition of CKD, the prognostication and management, everything depends on serum creatinine. And as we know, the definition of CKD is a GFR less than 60 ml per minute for more than 3 months. And the serum creatinine is not alone. You don't stop with serum creatinine. You do something called the eGFR calculation. What is this eGFR? It is an estimated GFR. There are 2 GFRs, measured GFR and eGFR. Measured GFR is what we calculate by a DTPA scan, or when you use a radioactive exogenous agent like an iothalamate. eGFR is where there is an endogenous marker like creatinine. You use that and use some parameters and do the calculation. There are a lot of eGFR calculations starting from our Cockcroft-Gault formula to the latest EPI formula. So how do you use this? We need a National Kidney Foundation. You use this eGFR app. It asks you for the serum creatinine, age and sex, and then whichever equation you choose, it would calculate and give you the eGFR. Which eGFR equation do you use? If you use your serum creatinine calculation by the IDMS method, you use the CKD EPI equation without race. The latest NEJM article in 2021 said that race should not be used. It was earlier thought that black people have a higher muscle mass and so they have higher serum creatinine, and so you would miss out on CKD, the lowering creatinine. But now it is clearly proven that race does not play a role. So if your lab uses IDMS method for estimating serum creatinine, use CKD API. If it uses enzymatic or Jaffe kinetic method, use the MDRD equation. So what is the clinical take home? I give you a scenario where there are 3 people, an 18-year-old athletic boy with 70 kg weight with a creatinine of 1.3, a 70-year-old man with body weight of 40 kg with a creatinine of 1.1, and a 50-year-old lady 50 kg with a creatinine of 0.9. Who has the best renal function? If you look at the creatinine alone, you would think that the 50-year-old lady has the best creatinine and so the best renal function, while the 18-year-old boy has 1.3, which is a little bit high. But when you use the eGFR equation and calculate the GFR, you find that the young boy has a GFR of 80 ml per minute, the elderly man has a GFR of 68 ml per minute, while the middle-aged lady has 75 ml per minute. So that is why the serum creatinine does not translate into eGFR. You have to do the eGFR equation. It just takes 2 minutes on your cell phone to calculate the eGFR and write it down. That is how you diagnose, you state CKD, and also you prognosticate. Next is, after the creatinine and eGFR, urine. So urine is called liquid gold because urine examination is a simple, inexpensive test. You don't need multiple gadgets, can be done anywhere. You just need a trained person and a microscope to do the urine exam. It provides a serial story that unfolds one day at a time. You can keep on doing the serial examinations every day and it would show what's happening to the kidney and what's happening in the blood, because kidney filters 25% of cardiac output is taken by the kidney. A skillful and motivated urine examination provides a window into the kidney, hence it's called a liquid biopsy. One important thing is we have to instruct the patients how they should collect the urine. Many times we forget to do, the lab also does not do. The patient should be asked to collect the first or second morning void urine. They should avoid strenuous physical effort before they give the urine because that can lead to false proteinuria. External genitalia should be washed with water. In male, the glands should be retracted. Females, the labia majora should be spread, and the midstream clean cat specimen should be collected. Females should be instructed not to collect the urine during menstruation, and a proper wide-mouthed urine container should be given to avoid contamination. The sample has to be preferably examined as early as possible within 1 hour. If it is more than 1 hour, it has to be refrigerated to 4 degrees for 4 hours. If it is more than 4 hours, it is transported from a collection center to a central lab. The lab needs to use preservatives. These preservatives can again impact the chemical analysis of urine. So all these are very vital for us to get a proper urine exam, which is a very, very important test. When you do a complete urine analysis, you look at the physical, chemical, and microscopic examination of the urine. In physical exam, you look at the clarity. It just needs to, you need to look at the urine. If it is milky white, you know the diagnosis, it is chyluria. If it is cola colored, you know it's a glomerular disease. For hematuria, you don't need an expensive test. Look at the urine, you will know the color. A purple urine shows you that it is purple bag syndrome. So color is important, volume is important to know oliguria. When you are evaluating diabetes insipidus, the odor is important. We have all heard in our first year physiology of the fishy odor, mousy odor of urine, which will give you the diagnosis. Osmolality is important when we are evaluating hyponatremia and diabetes insipidus. So all these components are important. In chemical examination, we look at the pH, whether there is an acidosis. So a patient with acidosis, you diagnose renal tubular acidosis. The difference between proximal and renal tubular acidosis is mainly by looking at the pH. If somebody cannot bring down the urine pH to less than 5.5, it means it's distal RTA, whereas we know that proximal RTA, they can always acidify the urine. Proteins are important. It is the diagnostic component of diabetes with CKD. Albuminuria starts much earlier than the loss in GFR. So urine protein evaluation and urine albumin evaluation and quantifying the albuminuria by doing a urine albumin creatinine ratio is very vital in picking up glomerular disease. Similarly, heme, blood in the urine can be positive because of RBCs, blood myoglobin, and you can differentiate by very simple tests. Next important is looking at the urine under microscope for casts. If you find an RBC cast along with dysmorphic RBCs and acanthocytes, you know that it is a glomerular disease. If you find fatty cast, it implicates nephrotic syndrome. A pus cast shows that it is pyelonephritis. Crystals are very important. Uric acid crystals. We had a session on gout. And crystals due to drug injury. Ciprofloxacin produced very distinctive crystals. Acyclovir, indinavir, all these produce very distinctive shaped crystals. When you do a proper urine microscopy with the clinical scenario, you can pick up that it is a drug-induced AKI. And you look at the epithelial cells, malignant cells, and microorganisms. So the urine examination is a very vital test which is not to be neglected, which will give you a score of information. So I just conclude with a case vignette. A 73-year-old female who's a hypertensive coronary artery disease, COPD, known case of CKD stage 3A, gets admitted to the critical care unit with community-acquired pneumonia. She is hypotensive. She is needing non-invasive ventilatory support. She started on injection ceftriaxone and azithromycin as is the protocol for treating pneumonia, and she is given IV fluids and inotropes. Her serum creatinine is 1.3, but over the first 3 days it goes up to 1.9 milligrams per deciliter. Subsequently, the patient's clinical situation is better. Her fever settles down, her hypotension settles down, she is off inotropes, her respiratory status has improved, she is taken off ventilator, but paradoxically, the creatinine keeps increasing to 2.7 milligrams up to day 9, and on day 10, it is 4.1 milligrams per deciliter. Urine examination is normal. Automated urine analysis shows 1 plus proteinuria, 1 plus blood, and ultrasound shows 10 centimeter kidney size, no obstruction, altered echo texture. So what is the diagnosis? Why is the patient's renal failure worsening when all other parameters are improving? The thought process is whether it was a pre-renal AKI to start with because of hypovolemia, hypotension. In that case, she should have improved. Or has she already gone into an acute tubular necrosis because of which there is a delay in improvement, but why is the creatinine worsening? Or it could be something else, whether it is a IRGN associated with pneumonia, or is it not infective? Is it a pulmonary renal syndrome? Is it a vasculitis in an elderly person? So these are all the thought processes. So the urine sediment is done by the physician, and they look specifically for RBCs, dysmorphic RBCs and RBC cast because there was a 1 plus hematuria. But they do not find dysmorphic RBCs. The RBCs are isomorphic. Many times in the ICU, the patient is on Foley's, you find RBCs due to trauma. These are isomorphic RBCs. But surprisingly, there are a lot of WBCs and WBC cast. The lab reports it as WBC. They don't say whether it's neutrophil or eosinophils or basophils. You have to do a dedicated staining and look for the eosinophils, and Hansel staining showed lot of eosinophils. Once you find lot of eosinophils in the urine with AKI, the DD becomes narrow. So you have atherosembolic AKI, drug-induced acute interstitial nephritis, or an eosinophilic granulomatosis with polyangiitis. ANCA was negative. The clinical picture is not like an EGPA. Probably it could be AAN because the patient was given ceftriaxone. Cephalosporins and ampicillins are the commonest cause of acute interstitial nephritis. So now the diagnosis is probably AAN. But the kidney function, so ceftriaxone was stopped because it's already 10 days and the patient is becoming better clinically, but the creatinine continues to worsen. It comes to 6.5 milligrams and vasculitis workup comes as negative. The patient is being advised to undergo dialysis and she is advised renal biopsy, but the patient and relatives are not willing. After careful deliberation that it could still be acute interstitial nephritis and we are sure that the infection is under control, we start tablet prednisolone 60 milligram OD, which is the treatment for acute interstitial nephritis, drug induced, and over the next 8 days we find that the serum creatinine starts coming down up to 1.5 milligrams per deciliter. The patient becomes clinically normal and the patient is discharged successfully. So this is where a simple urine exam, bedside microscopy, has helped us to treat the patient, elevate the patient care. So we know that eosinophils, urine leukocytes can be part of AIN. We know that it could be AIN. We use that theory into the patient's practice and we elevated the patient care. So this is just to say that in the era of modern medicine where we have high-end technology, the technology is built only on the basics. So we should not forget the basics, which are urine examination, serum creatinine and the eGFR, which is very important to save the kidneys. Thank you. I thank the organizers for giving me this opportunity.
Thank you, Radha ma'am. As you rightly pointed out, urine analysis is the gold standard. It is always considered as a liquid gold and also as a poor man's biopsy, urinary cast. And regarding Professor Soundarajan sir's topic, rabies, it will be very easy to diagnose or treat rabies case in a tertiary care. But it will be very difficult to pick up the doctor who first sees the case in the periphery. While we work in PHC or GH, they will always present with the atypical features, that the person is not eating for 2 days, the person loves to sit in a dark room, and the person vomits whatever takes. Like that they will tell atypical history. So we should have a high degree of suspicion in picking up the cases. So it was an extensive account on rabies, sir. It was an excellent talk, sir. Thank you, sir and ma'am. Time for felicitation. Are any questions from the audience?
Next, I would like to invite Dr. Imran to speak on PCI in diabetic CAD, how different it is.
Pointer இருக்கமா? Pointer இல்லையா? சரி ஓகே. இது அதில் இருக்க வீடியோ ரன் ஆச்சா பார்த்தீங்களா? இல்லை கொஞ்சம் பாருங்கள், அது வீடியோ மட்டும் ரன் ஆக பாருங்கள். கீழே வாங்க. கீழே வாங்க. கீழே அடுத்து அடுத்து இது ரன் ஆகலை. கிளிக் பண்ணுங்கள். ரன் ஆகலைல்ல. சரி, நான் இது ஃபோட்டோஸ் போட்டு வச்சுட்டேன். சரி, ஃபஸ்ட்லேருந்து வந்துடும். ஸ்லைட் நானே மாற்றிக்கணுமா, நீங்கள் மாற்றிக்கணுமா?
உங்களோட கண்ட்ரோல் தான்.
Good morning, one and all. I'm Dr. Imran Niazi, Assistant Professor of Cardiology in Government Vellore Medical College. At the outset, I would like to thank the organizers for giving me the opportunity. The topic for the day is PCI in diabetic patient and what is new in this. So, பின்னாடி வரணும்னா
Excuse me, sorry for the interruption. I would like to invite Dr. Oliver John to chair the session.
Okay, இது யூஸ் பண்ணிக்கிறேன். Regarding the presentation in diabetic patients, usually apart from routine typical chest pain, patient with the diabetes have atypical presentation. Some patients have a silent ischemia and they usually present with anginal equivalent symptoms like dyspnea, and other symptoms, nausea, vomiting, and incidence of sudden cardiac death is high in diabetic patients. And usually these diabetic patients have impaired LV function because of atherosclerotic aortic disease, associated hypertension and left ventricular hypertrophy, obesity, microvascular dysfunction, and endothelial dysfunction, autonomic dysfunction, and associated metabolic abnormalities and diastolic dysfunction. These patients tend to have an impaired LV function, which will have a long-term effect on after revascularization. And once a diabetic patient is diagnosed to have a CAD, which is significant CAD, is considered to have a 70%, more than 70% stenosis in a blood vessel, or more than 50% stenosis with symptoms of ischemia. So once all this been diagnosed, for if the patient is having asymptomatic silent ischemia, then the question for revascularization should be considered, whether there is large amount of ischemia, or if is whether suitable for revascularization or not, based upon his coronary anatomy, comorbidities, etc. If it is symptomatic patient, we divide into stable and acute coronary syndrome. For stable patient, again there is a choice for revascularization if optimal medical therapy fails. And in non-ST elevation MI and ST elevation MI, it is only revascularization, either PCI or CABG. So what is more specific about a coronary artery in a diabetic patient when compared to a non-diabetic patient? In CAG, we usually have multi-vessel involvement, and we tend to have more diffuse and long segment disease, and usually the caliber of the blood vessels is very small, and these patients tend to have more complex CAD and more incidence of chronic total occlusion and heavy thrombus burden in acute coronary syndrome setting, and these patients tend to have heavily calcified vessels. So coming to the guidelines perspective, whether a diabetic patient with PCI, with CAD needs PCI or CABG, there are certain characteristics favoring PCI as well as CABG. So for PCI, any presence of severe comorbidities and advanced age and frailty where complications of CABG are more, and if patient cannot recover much after surgery, so PCI favors more. And in CAB, a patient with reduced LV function who has contraindication to prolonged dual antiplatelet therapy and recurrent instant restenosis and multivessel disease with syntax score more than 23 and severely calcified vessels, all these patients are more favorable for CABG. So this is the guideline recommendation. So you can see the level of indications for CABG as well as PCI. Any patient with proximal LAD stenosis, they have equal choice for either PCI or CABG, but without proximal LAD stenosis, either in one vessel or double vessel disease, PCI scores more than CABG. Whereas in multivessel or triple vessel or left main disease, the presence of syntax score more than 22, that is if he falls under intermediate or high risk category, CABG scores more than PCI in multivessel and left main disease. So this is the gist actually. So any diabetic patient with CAD needing revascularization, first whether if it is single or two vessel disease, if it is a non-proximal LAD or non-left main disease, and if there is high surgical risk or any contraindication to surgery and in age more than 80 years, PCI is the first choice. If there is multivessel disease with proximal LAD or left main involvement, or in patient with ISR, CABG is preferred. So these are the trials for revascularization in diabetic patient: Cardia trial, Synergy trial, Freedom trial, and Barry 2D trials. So I'll just give you a gist for Freedom trial alone. So this is the syntax score according to 2024 ESC guidelines. This score is nothing but score for determining the suitability of PCA versus CABG. This syntax app is actually available in our Android or iPhone. We can just download that and input give the inputs so that we derive a score. If it is less than 22, they are ideal candidate for PCI. If it is more than 23, they are ideal candidate for CABG. So this is the Freedom trial, and they have showing the primary outcomes and death for a diabetic patient with the PCI and CABG, and CABG actually favors well with for diabetic patients. So this is done with diabetes and non-diabetes patient and in patients with multivessel disease. Again, CABG scores well in diabetic patient and multivessel disease. So who should undergo PCI in a diabetic patient? for those who are having stable parameters and stable ischemic heart disease with any focal disease and with a low syntax score, PCI is considered to be very safe. And in acute coronary syndrome setting, obviously, primary PCI of the culprit artery must be done immediately and followed by heart team consultation for CABG for the non-infarct related obstructive disease. And there must be strict glycemic control during peri-ischemic and period, and there should be very good adjunctive pharmacotherapy given. So during PCI, what we do overcome in a diabetic patient is like we have the usage of increased number of stents in a diabetic patient compared to non-diabetic patient, and there is increased incidence for slow flow or no reflow because of endothelial dysfunction, and there is high chances for coronary artery dissection and vasospasm. And usually in a diabetic patient, there is increased use of imaging techniques and calcium modification therapies like rotablation, orbital atherectomy, cutting balloon, scoring balloon, and all this will increase the cost burden for the patient. Again, post PCI, we do have increased instant restenosis in a diabetic patient because of poor endothelial healing and increased chances for stent thrombosis, stent infection. Then there is high chances for revascularization and repeat procedure, and there is high incidence for contrast nephropathy if the patient is having underlying diabetic nephropathy prior to PCI, and there is high increased rates of pulmonary edema in diabetic patients. So this is a image, actually video is not running. So this is a stent actually, this stent thrombosis, actually acute stent thrombosis in a diabetic patient. So this is a thrombus actually. So this is a thrombus burden in mid RCA. This is a stent infection. So abscess or stent infection is common in diabetic patient. This is a dissection actually. So this is an LCX vessel dissected and simultaneous dissection of LAD vessel, a mid LAD as well. This one is a peculiar rare case, very stent abscess actually. This is very, very rare, which is seen in a diabetic patient after 1 month of PCI. Due to, like one of the risk factors, poor glycemic control, patient actually discontinued diabetic drugs. He just followed only cardiac drugs alone. And this is one more case for stent, RCA stent restenosis. So this is a case example for diffuse disease. These blood vessels are very thin and these are not amenable for revascularization either with PCI or CABG. This patient was also deferred for CABG and was left on medical management. So this is so what are the specific challenges in diabetic patients who need revascularization? So this diabetic patients usually have diabetic arteriopathy, and they have a high rate of restenosis and development of actually vulnerable plaques outside the stented segments, so which is more dangerous actually, and they have a high incidence of medial calcification and heart failure, chronic disease. They also have altered pharmacokinetics, altered pyridine metabolism, like clopidogrel resistance is more common. So why ISR is more common in these patients? Because of the inflammatory response, there is high mobilization of progenitor cells and ingrowth of smooth muscle cells, and there is accelerated neointimal hyperplasia leading to high restenosis and increased TGF beta signaling and direct influence of hyperglycemia and smooth muscle cell migration. Usually it is common after placement of longer stents or in arteries with smaller diameters. So all this inflammation and hereditary leads on to hypercoagulability by stimulation of procoagulant factors like fibrinogen, von Willebrand factor and factor VIII, and there is always an associated endothelial dysfunction and oxidative stress and release of inflammatory cytokines and reduced levels of anti-thrombotic factors. All this favors the for the formation of stent thrombosis or instant restenosis. So this is the pathophysiology. Already patient has vasculopathy, chronic disease and altered antiplatelet pharmacokinetics. They tend to have a smooth muscle cell proliferation leading on to neointimal hyperplasia and restenosis. And when there is increased platelet reactivity and formation of prothrombotic neointima, that causes stent thrombosis. So this is again an RCA showing stent thrombosis. This is the stent actually. It has shown complete thrombosis. This is an LAD thrombosis. This is the stent. So increased platelet activation and addition has more prothrombotic neointima after stent placement, leading on to stent thrombosis. They have 25 to 80% increased risk of stent thrombosis when compared to non-diabetic patient, and these patients may benefit from intense antiplatelet therapy after stent placement. So diminished benefit, usually diabetic patients has diminished benefit after PCI because of increased risk of target vessel restenosis and more diffuse atherosclerosis, leading on to greater disease progression in non-target vessels also. They have higher rates of major adverse cardiac events in late follow-up for PCI treated patients, leading on to increased requirement for repeat revascularization. So this is the limitation for current drug-eluting stent in diabetes. They have poor vessel healing due to slow endothelialization and increased inflammatory response, leading on to thrombosis as well as focal edge or diffuse instant restenosis. So what are the adjunctive pharmacotherapies that can be used in diabetic patients extra, like glycoprotein 2B3A inhibitor therapy, Tirofban? They provide additional benefit, and they also reduce the incidence of periprocedural myocardial infarction, stent thrombosis, and repeat revascularization. These patients tend to, they need usually prolonged and intensive dual antiplatelet therapy, that is aspirin along with either prasugrel or ticagrelor, and IV nicorandil followed by oral nicorandil therapy can be used for slow flow or no reflow phenomenon. And these patients must have strict glucose, lipid and BP control during peri-ischemic period as well as in the post-operative period and for the lifelong. So prasugrel actually has 2.2% absolute risk reduction in major adverse cardiac events and 0.6% risk in increase in major bleeding events. There is a net clinical benefit with a 4.8% absolute reduction, risk reduction in MACE. And ticagrelor has a 1.9% absolute risk reduction for major adverse cardiac events. So these are the latest therapeutic options available. Bioreabsorbable scaffolds, drug-eluting balloons, intravascular lithotripsy, atherectomy for diabetic patients with undergoing PCI. So conclusion, PCI is still a good and viable option in selected diabetic patients. For those without proximal LAD, single vessel or two vessel disease, PCI is considered to be a good choice. With the proximal LAD stenosis, multi-vessel and left main involvement with syntax score more than 23, CABG is a better option. So always a multidisciplinary approach and heart team consultation is usually beneficial, and careful planning and long-term care is very, very critical to avoid long-term complications like instant restenosis and stent thrombosis. Thank you.
Thank you, sir. It was a nice account. Incidence of dissection and abscess.
Yes, madam.
And how to proceed with that, sir?
Incidence is actually low, ma'am. It is usually 1 or 2% only, but still that 1 or 2% occurs only in diabetics. Non-diabetics we usually don't see spontaneous dissection.
And how to manage such situations?
Dissection, you have to put one more stent, ma'am. That is the increase, the number of stents will increase. That will be both cost this thing, and as well as it will be a burden for they should have a very prolonged intensive antiplatelet therapy for the patient, ma'am. And one more thing, what you asked, ma'am? Abscess, prolonged antibiotic, IV antibiotic therapy, ma'am. Usually IV meropenem for 14 to 28 days, ma'am. We have treated patient and abscess have subsided, but once there is always a chance for reformation, ma'am. So usually we bypass graft should be put.
And you continue with that old stent?
Yes, we'll leave off that, ma'am. We should go for CABG.
Thank you, sir.
Very nice presentation, sir. So we are telling about elderly people. So normally diabetes itself causes autonomic dysfunction. So and moreover, aging itself produces autonomic problems. So we mentioned 80 years. So what are common other presentations, atypical presentation elderly that present as that's the first question. Second question is telling about PCI. Normally CABG is preferred over PCI, whereas elderly mentioning about PCI.
Where surgical mortality rate is high, sir. So we usually tend to do PCI. Usually diabetic patients, elderly, we leave them with medical management. But if the patient is willing for PCI, we do tend to explain the risk. And there are many options available now. Drug-eluting balloon is an option without a stent. So these patients also need antiplatelet therapy, but not at an intensive antiplatelet therapy with prasugrel or ticagrelor. They need only aspirin and cloplet because of decreased risk of bleeding, sir. So we tend to continue that.
So in case PCI is done, any complications post PCI in elderly people?
That's what the heart failure is common, pulmonary edema is common, contrast nephropathy is very common. So all these are very common, sir.
Thank you, sir. So any questions from the floor?
Thank you so much, sir.
Thank you, sir. May I request our chairpersons to kindly present a memento to Dr. Soundararajan as a token of appreciation. We now request the chairpersons to felicitate Dr. Radha Vijayaraghavan with a memento. We also request the chairpersons to hand a memento to Dr. Imran. Now I request Dr. Satish Kumar sir to present a memento to our chairperson, Ms. Dr. Meena Kumari ma'am. Now I request Dr. Venkat Ramanan sir to present a memento to Dr. Satish Kumar sir. Next, I request Dr. Satish Kumar sir to present a memento to Dr. Bijan sir. Thank you everyone for your valuable contributions. This is the last session at Hall B. I request everyone to assemble at Hall A. There are 3 more sessions going on there. It will be very interesting for you to attend.
After that, the validity function also be there in Hall A. Please come join us in Hall A.
Thank you.